Yes, we can start.
Hello. Am I audible?
Yes, Bharti, you are audible.
Dr. Lakshmi, am I audible?
Yes.
Okay. So we just start some important issues. So till I think in 5-10 minutes more people will join. So good evening everyone. Today we are on Chai Pe Charcha FOGSI ICOG webinar. That is the third thought of Chairperson ICOG Dr. Lakshmi Khande to have some important clinical issues that we must be discussed together. And today this is the second series. On the 28th Feb we have done on how to reduce cesarean section, and today we are having the safe abortion practice with saving girl child in India. Basically सुरक्षित गर्भपात बेटी बचाओ के साथ. Though all know that we are mainly concerned with the providing the safe delivery, safe abortion practices to the women. So how it is linked with Beti Bachao ke saath? Because it is Government of India policy that safe abortion services should not be jeopardized in preventing sex selection. So that's why this theme is kept, and in next 2 hours we are going to have a very important discussions related to this theme. Like the first of all, we have our great expert, Dr. P.K. Shah sir and Dr. Noza Shariar, and Dr. P.K. Shah sir, he will join soon, and I think he has joined already.
Here, Bharti.
I have joined Bharti.
Yeah. Good evening, sir. Good evening.
Good evening.
Yeah, so we all know that Dr. P.K. Shah sir, he's a past FOGSI president, past Mumbai Obs and Gynae Society president, past president of IFUMP. We all know he's about renowned radiologist, renowned sonologist, and has with the past done lots of works related to MTP. So welcome you, sir, in this webinar as an expert. And Dr. Noza Shariar sir, that he will join at 6 p.m. If he is not joined, he will deliver his talk. So, first of all, I would like to welcome Dr. Lakshmi Khande, the ICOG chairperson. We all know how much she is academic and doing efforts. So now for Lakshmi Khande, madam, for welcome of expert. Yeah.
Yes. Very good evening, one and all. Friends, we all are aware that unsafe abortions are the third leading cause of maternal mortality in India, and close to 8 women are dying from causes related to unsafe abortion each day. This is the statistics given to us in 2022. And friends, this is in spite and despite of liberal MTP Act. Even today, 67% abortions in India are unsafe, which is a huge number. So today we have organized Chai Pe Charcha to discuss the reasons behind these statistics and how we all can provide safe abortion care in sync with DCPNDT and FOGSO Act. Friends, so we all will be discussing on this great issue of relevance. I thank FOGSI President Dr. Rishikesh Pai and Secretary General Dr. Madhuri Patel for their constant support and gratitude. I acknowledge the presence of our Vice Chair ICOG Dr. Parag Biniwale, Secretary Dr. Ashok Kumar, and 2 experts who have spared their valuable time, Dr. P.K. Shah sir and Dr. Noza Shariar. I also take this opportunity to welcome all the speakers, panelists, and dear delegates. So let's have happy tea time with great deliberations. Back to Bharti for further proceedings.
So now I request Dr. PK Shah sir as expert to have their comments on this topic or they give their wisdom words. Yes, Dr. PK Shah sir.
Thank you, Bharti. First of all, I must thank office bearers of FOGSI, Dr. Rishi, Dr. Madhuri, office bearers of ICOG, Dr. Lakshmi Shikande, Chair, Dr. Parag, Vice Chair, Dr. Ashok Kumar, Secretary, for giving me this opportunity to be with you all. Bharti, being the convener of this series, I'm really happy to see that you have picked up practical aspects of our practice. There is no point talking on webinar topics which are totally theoretical. I think this is going to really impart a lot of knowledge to people who have joined us today. And the subject chosen is Surakshit Garbhapat, Beti Bachao ke saath. As Dr. Lakshmi Shikande gave you the statistics, it's very sad that we lose almost 3,000 women every year because of unsafe abortion. And I don't know how many more must be dying because of unsafe abortion, as many deaths are hidden. So it is so nice to see that we are going to completely cover abortion, current scenario in India, then PCPNDT Act and MTP Act, which is the panel going to be conducted by Dr. Bharti Maheshwari herself. And then we have Dr. Parikshit Tamp, Dr. Richa, and icing on the top, Dr. Nozar Sheriar, who will be giving us the last talk on giving women the safe abortion they deserve. I think the whole program is very useful, and I wish Dr. Bharti all the very best for all her future endeavors, and I wish this program a grand success. Thank you very much for involving me. Bharti, let's go ahead.
Thank you, sir. Thank you so much. Bharti, please unmute.
Bharti disappears in between. She has shown her full-time photograph.
Today she is, I think, having some net problem. No problem.
So thank you, sir, what you have given. And now I invite our first speaker, none other than Dr. Lakshmi Shrikhande madam, that we all know that she is the chairperson ICOG, and she is very much keen in doing the all academic programs. So now to Dr. Lakshmi Shrikhande madam for her topic, abortion scenario in India. Yeah.
Yes. Thank you so much, Bharti, for your kind words. Friends, let's see what data says as far as abortion in India is concerned. The latest National Family Health Survey shows that around 3% of total pregnancies in India, they end up in abortions, while 4% are from urban area and from rural area, the figure is 2.5%. Of course, the trend is not uniform throughout the country, as we are a diverse country with urban and rural spread of the population. Now, what are the reasons given for abortions? You can see here, almost half of the Indian women who aborted, 47% said that the reason was unplanned pregnancy. 10% said the last child was too young to have the next birth. And among the remaining reasons, you can say that there are other reasons like health issues, contraceptive failure, so on and so forth. Of all pregnancies, this is the figure, the statistics from 2015 to 2019 by our government of India. And out of all pregnancies in these 5 years, 44% were unintended. And of all unintended pregnancies, 77% ended in abortion. This is the news published in Indian Express. And when you see the data from the developed and developing countries, you can see that the unplanned pregnancies are more in developing countries as compared to developed countries. United Nations Population Fund state of the World Population Report 2022 stated that 67% abortions in India are unsafe. They also said 8 women die each day because of unsafe abortion. 1 in every 7 unintended pregnancy in the world occurs in India. According to the 2016 study published in Lancet and according to WHO, 56 million abortions took place globally each year between 2010 and 2014. And it was a proud moment for India when its proactive parliamentarians, they legalized abortion with the historic Medical Termination of Pregnancy Act of 1971, creating a framework meant to protect women from the grave risk of unsafe abortion. Unfortunately, in spite of this legislative protection, unsafe abortion remains the third leading cause of maternal mortality in India. What do we mean by unsafe abortion, friends? According to WHO, an abortion is considered safe only if it is done using a method recommended by WHO. The UNFPA report noted that the amendment to MTP Act 2021, which we all are aware, it appears encouraging, but they also added that a lot more needs to be done to prevent unsafe abortions and maternal mortality. We all know that now Supreme Court has expanded the law to ensure access to abortion for all women regardless of marital status up to 24 weeks of gestation. So you all can see what was there in 71 Act and now what is there in the MTP Amendment Act 2021, which is more liberal. It is covering even unmarried women up to 24 weeks. Only one RMP is required till 20 weeks, 2 RMP opinion till 20 to 24 weeks, and the fine was up to rupees 1,000 in 1971, which has been increased in 2021 amendment. So friends, we do have a liberal MTP Act, but even then, is abortion a criminal offense in India? Yes, the IPC makes abortion, that is induced miscarriage, a criminal offense under section 312. So what is the relation between MTP Act and IPC section 312 then? Because the MTP Act is the exception to this law. The law safeguards registered medical practitioners by laying down certain conditions under which they can terminate the pregnancy. This is just to give an overview of how liberal and our government of India is giving miscarriage leaves to our women, because India was the first country to legalize miscarriage leave. The Maternity Benefit Act 1961 states that in case of miscarriage, a woman will be entitled to paid leave for 6 weeks immediately following the day of the miscarriage. Now, why? Because the question still remains, why women in India are seeking unsafe abortions when we say that we do have a liberal MTP Act. So let us go through this real story. Chitra, she had to travel more than 40 kilometers from her home to city of Gurgaon to have an abortion so that her families would not find out. The contraceptive failed, and in her words, I did not wish to have a child. I was repeatedly questioned and treated rudely by the doctors as well as nurses and other staff at the clinic. This is the story of 20-year-old student. My boyfriend was there to support me, but I was afraid that they would force me to ask for my family's permission, and I would never want to go through this ordeal again. So lack of privacy. In India, a woman does not require the approval of her husband, partner, or family if she is an adult of sound mind and wishes to get an abortion. Despite this, there are several hurdles that women face in a society that is highly patriarchal. Women find it difficult to access abortion. Often, the privacy and confidentiality of the woman is not protected, and a lack of access added to these two issues, they contribute to huge number of unsafe abortions in India. 2015-16 National Family Health Survey showed that only 20% of the abortion took place in public healthcare facility. That means private clinics and hospitals, which are concentrated in urban India, they are responsible for 52% of abortions. Even 17 to 20% of abortions in rural India do take place at home. So it is high time that abortion is recognized as a reproductive need. Let us go through the profile of women who seek abortion. 57% of the women who received abortion at public health facilities, they were poor, followed by 21% who were middle income and 22% who were rich. We need to have improved availability of safe abortion services at the primary level in rural India. Now, what is the profile according to educational status? If the woman is educated and rich, they opt for abortions in comparison to the uneducated woman. The profile as far as the weeks of pregnancy is concerned, almost 78% abortions they take place when the pregnancy is less than 10 weeks. 91% abortions they take place in the first trimester, that is when it is less than 13 weeks. Now, what is the relation between MTP Act and FOGSI Act? We all have gone through the FOGSI Act. Although this act safeguards the life and rights of children, it fails to differentiate between consensual sex and offense, and it also does not address the gray area of early marriage, which is still rampant in rural parts of our India. Any sexual activity with person below the age of 18 years is deemed as statutory rape. As the act fails to differentiate between offense and consent, it poses a huge barrier to access the sexual and reproductive health services for adolescents. Moreover, this act has the requirement of mandatory reporting, and failing to do so can lead to penalty with imprisonment of a fine. And this requirement impacts the adolescent sexual and reproductive health, as it results in denial of variety of these services to these adolescent girls. Because we health professionals, we play safe. We do not want to get entangled in any legal proceedings, and thus it interferes with the sexual and reproductive health. Now, the safe abortion and gender bias sex selection, which is the theme for this today's Chai Pe Charcha, that is Surakshit Garbhapat Beti Bachao Ke Saath. You all can see the figures why Indians, they prefer sons over daughters, and because of this preference, we have a skewed sex ratio, which is the result of this gender-based discrimination. The last population census, which was conducted in 2011, the report we have of 2011, they have shown that the country is having only 943 females per 1,000 male. Child sex ratio, which shows the number of girls per 1,000 boys between the ages of 0 to 6, fared even worse, with just 918 girls for every 1,000 boys in this age group. We know the various reasons, and economics here is very, very straightforward, and that is why in India still everyone prefers son over daughters. Now let us see the impact of COVID-19 on the access to safe abortion services. We all have gone through this COVID epidemic, pandemic, and as a fallout of this lockdown, because of COVID-19, millions of couples in the countries, they were deprived of availing the contraceptive services and the safe abortion services. So what was the solution to this? The expanding telehealth to include information, support, and services around medical abortion can be a safe and revolutionary way to expand access to safe legal abortion. Public sector provision of abortion, we know, has several challenges, especially during COVID pandemic, because of the lack of trained staff, equipment, supplies, and non-judgmental care being provided to these women. Telemedicine for abortion can not only help address gaps in the public sector provision of safe abortion, but can also serve as a viable choice even when quality services are available, since it would reduce the burden on the health infrastructure by reducing in-person visits and enhancing privacy and confidentiality needs of clients. By expanding telemedicine to include medical abortion, India can forge the way ahead for safe abortion access, not just during the pandemic, but also creating an opportunity for long-lasting impact. So friends, this was all an overview about the current scenario of abortion in India. We know that provision of safe, effective, and accessible abortion service is a priority in the government of India's current reproductive, maternal, newborn, child, and adolescent health program. And we at FOGSI ICOG, we all are working with Government of India towards providing safe abortion services to our women. But we at individual level should also cater towards providing safe abortion practices to reduce this huge number from 67% of unsafe abortion to bare minimum, that is negligible number. So thank you, friends. No woman can call herself free until she can choose consciously whether she will or will not be a mother. So thank you. Thank you so much for your patient listening.
Thank you, madam. Wonderful talk. And in fact, you have helped me a lot because we are going to have a panel and we have lots of such issues what you have covered. So it is really very eye-opening also, because we could know that this is the status of in India, and though we have among the very first ones who have started the legalization of abortion in India, and still we are having not a satisfactory condition, especially the abortion related morbidity and mortality. So now, without doing any delay, we come to the next session, and that is the panel on safe and legal abortion in India in perspective of all acts and law. And I have very good esteemed panelists with us, those who have not only worked in their field as a obs and gynae, they are leaders as well as they have worked a lot for the MTP. So first moderator myself, Dr. Bharti Maheshwari, you all know me. I am a head of department Muzaffarnagar Medical College, as well as chaired FOGSI MTP committee for last 3 years. And so I have a lots of experience, and I have explored a lot about the MTP status and its documentations and all. And presently I am a governing council member ICOG. And then panelists, I have esteemed panelists with us, and the first is Dr. Shamal Seth. You all are very much familiar with Dr. Shamal Seth. He is a very dedicated FOGSian as well as the past MTP committee chairperson. Then Dr. Anju Soni, we all know that she is at present chairperson HIV and AIDS committee, and she is also very dedicated FOGSian. Then we have a Dr. Pragya Mishra. She is the founder secretary Bihar chapter of ISAR. At present, she is the secretary of ISOPA, but she was also remained a committee chairperson fetal medicine. Then we have a Dr. Sneha Bhumiyar. We all know that dedicated FOGSian, as well as she is the chairperson breast committee, and she is also a governing council member. And Dr. Vishwajyoti Guha, that he has also joined, though he has some, he was traveling, has some issues, but I see her. So welcome, Dr. Vishwajyoti Guha, sir. So now we come to the panel. I hope that all panelists, they are unmuted themselves, and they are present here. So we come just a background. We will take around 30 minutes to finish this panel, and this time is now. I am seeing my screen. So we, as Dr. Lakshmi Madam already declared or already told that MTP Act, it was in a country exhibited in 1971 to discriminalize abortion, to prevent unsafe abortion, safety of doctors and women both. But unfortunately, we couldn't achieve that goal till yet, and still in globally we say that 63,000 women die each year as a result of an unsafe abortion, and in India nearly 15 point every day 13 women die in India. So that is a big figure, and nearly 15.6 million pregnancies are terminated every year in India. So this topic definitely need attention. That's why this is kept in today's Chai Pe Charcha. Here just I want to share that we have a one document which recently we have released. It is available on the FOGSI website also. That is MTP Act FOGSI Focus, where you can get all aspects of related to abortion, from abortion scenario, amendment, documentation, still clinical or issues, you can get it. So this is, I just want to share this slide. I share everyone. That is a WHO slide that they have declared that you can prevent unsafe abortion through comprehensive sexuality education, access to affordable contraception, as well as safe abortion care. And safe abortion must be provided and supported by a trained person using either tablet or surgical procedure. And this is a WHO in Geneva. This statement is released that though every country is doing lots of efforts for preventing unsafe abortion or related its morbidity and mortality, but regarding safe abortion, only services are not enough. Respect for women's informed and voluntary decision making, autonomy, confidentiality and privacy, with attention to adolescent and women with special needs. Only these things has to be covered to prevent the abortion related death and morbidity. And that's also last year all we together worked hard for the Surakshit Garbhopat Beti Bachao Ke Saath. That was we have done. And for this is the basics Government of India guidelines and the positioning of the abortion, that national policy is to make abortion safe and widely available as per the law. Abortion is legal for a number of reasons, but not for reason of selecting the sex of the fetus. Even today, 8% maternal mortality is due to unsafe abortion. So, safe abortion should not be jeopardized in preventing sex selection. So, this is the theme of today's this CME, that Surakshit Garbhopat Beti Bachao Ke Saath. Estimates indicates that about 9% of abortions are sex selective and 90% are not. So, this thing had to be keep in mind that of course sex selection and its prevention is an important, very important issue, and it should be taken care of. But where the safe abortions are needed, they has to be also provided. So now we comes to our panelists. So any panelist can have this question: what are now in keeping all these scenarios in your mind, now where we have reached, what are the issues we have to tackle, and what are the barriers for safe abortion services at present? Yes, who is going to take this question?
May I, Bharti?
Yeah, Dr. Shamal Seth. Yes, sir.
Now, we all know that MTP Act came into force in 1971, and there are so many amendments. MTP rules, regulations have been formulated. Recently, into 2021, we have got another amendment in MTP in a large scale. But still, abortion scenario has not much improved, although it's no doubt has improved to a little extent than what it was, say, 20, 30 or 40 years ago. But still, scenario is not good. There are several factors behind it. Most important factors as the accessibility and availability of these services. This is no doubt a huge factor. And if you can say, think of private setups, this is not going to be very cheap. So it's not, this service is not available in cheap. It cannot be available, in fact. Now, there are several things which have been made our job tedious and with some headache, like the maintenance of all those records, documentations, your botheration to send all those things to the CMOH at the end of every month. All those things are keeping ourselves away from the services. And you all know, even if you consider the last amendment, that confidentiality and privacy issue, this is absolutely, I think we should go against this issue to a large extent. We are having agitations, allegations against. There are many other issues which is imposed by the government, which we feel anti-doctor. Now, just imagine if privacy you cannot maintain of a patient, you are going to suffer an imprisonment of 1 year. What harm you are going to cause? You are not going to disclose the privacy of a patient who seeks MTB by riding on an auto, and you are declaring on a mic that I have terminated the pregnancy of this lady, that lady, that lady. We are not going to do that. Which are the other way we can disclose the privacy. Now, if the government allows the MTP kit to be sold to the patients over the counter, then what is the question of privacy? What is the question of confidentiality? So all these issues which are anti-doctor as well. And you know, there are many doctors still today, they are scared of doing MTB services because of all those rules and regulations. And they simply prescribe some drugs like misoprostol, allows the patient to bleed, and then stamping as a case of inevitable abortion or incomplete abortion, and they are just doing simple DNA procedure. So actual data or records of exact MTB cases are not coming. So all these issues, apart from these economic factors, there are policy matters from the part of the government, and you will be surprised to know that there are many CMOHs who are not aware of all these things, that they should get these forms to be filled in from the doctor. So all these factors making the abortion services still unsafe to most of the patients.
So, Dr. Shamal, you have told very clearly, and I know that you have worked a lot last 3 years when you were MTP committee, so you know the status. So that is true that there is a one very important factor that even researchers say that around 90% or more than persons, they don't know that they have a legal abortion facility in country. First thing, non-awareness. Second, social stigma. That is very important, that whenever someone has some abortion, so it is kahin na kahin linked with the sex selection. So even from with the doctors and with the patients also. Dr. Vishwadeep Guha, you are here. Dr. Vishwadeep, are you there? Anyone else if want to say some?
Yeah,
Yeah.
Dr. Bharti, if I can make some comments on this.
Dr.
As Dr. Shamal has very rightly pointed out, what are the challenges at all the levels, considering the women, the healthcare provider, and the policymakers. So, as far as the patient, he has talked about the unawareness of the availability of the facilities for abortion. So, abortion services has really traveled a long journey, right from the availability of abortion services to liberalization, legalization, and now the term which we are talking about is respectful abortions. So definitely availability and accessibility should be easily made available to the needful women. That's what actually we have to secure. Secondly, the service providers, they should have the appropriate knowledge and also how to help and inform the patient, talk about what is the cafeteria approach, till what weeks they should have what kind of abortion services. Thirdly, even on the part of the healthcare providers, if we talk about the record maintenance of record, how many types of records we have to maintain. Every time the policy is changing, and we have to even change, for 12 column, 14 column, and 16 column registers. All these things, definitely the privacy. I think the changing concepts also, considering the newer trends of, the term, the husband is now replaced with the partner, and also the married woman replaced by even the unmarried women for the failure of contraception. So if this knowledge is not available to the common man or common woman, I would say, so they can go for the unsafe abortion methods even till today, because they feel that the failure of contraception is meant only when the pregnancy is because from the husband. So all these things which are updated in the law amendments, they should be readily available to the common man as well, common public as well. So that's how I think it should be, the challenges should be overcome.
In fact, no, I think we are on the.
Dr. Bharti, can I?
Yeah.
Dr. Bharti, can I add?
Yes, please.
Just a single point. I always consider ourselves to be lucky that patients are not aware of. Otherwise, almost every alternate person of us who are providing MTB services might be in the jail, because it is very difficult to maintain the privacy. If a patient gets admitted, and to maintain all those formalities, you need to maintain that register. Now, if it is your own own hospital, you are working in your own hospital, you are a trained MTP provider, good enough for you. But if you work in another nursing home or another setup, it's very difficult to make them understand the entire procedure since admission to the discharge of the patient, how to keep his or how to keep her identity to be in confidence. It's very difficult. It's very difficult.
Okay, we have lots of issue to discuss. Dr. Pragya, Dr. You want to say any one?
I wanted to add, Bharti, I wanted to add.
Yeah, please.
Yeah, when we talk of this challenge, is the biggest challenge, which has already been pointed out by my previous speakers, is I think more than 50% of the cases, the abortions are sought after by taking a OTC pills, the abortion kit directly from the pharmacist, where the gynecologist is not even involved. Maybe I think it's more than 50% maybe, because a lot of patients will receive who come to us directly if they have already taken tablet from the medical store without anybody's advice and not taken properly, and then they come to us with all the complications and all the problems. So
That is very important.
there has been a huge shift from the patient going to the doctor to going to the pharmacist. There is a huge shift. This is what I have.
One issue, Dr. Anju. Dr. Anju, we have noted this issue. This is very important. We have lots of things we have discussed in future. In this,
important thing I want to
remain Grace. Yes, Dr. Pragya, your turn. What you want to add?
Yeah, just one quick thing. You know, the list of challenges that you've mentioned. First of all, thank you for inviting me for this panel. The challenges that you've mentioned, one very important thing, I'll tell you regarding the cost, which is not mentioned. See, government sector, forget about the government sector where it's free. But in the private sector, where more than 50% of the MTPs are taking place, patients are being misused because of the cost, especially, if she comes in the second trimester or if she's unmarried, she's young, then, clinicians are charging exorbitant rates, for those patients. So that's a big challenge and a big hurdle. And that's why, some young girls or women, unmarried ones, they would just go to the, to the paramedical staff, to the nurse or to the quack and get her MTP done. So
that's very true. So all my esteemed panelists has kept these issues that it is really today we have to handle. That is first unawareness about the law, misuse of medical method, what Dr. Anju said, missed ectopic, lack of providers, social factors like adolescence, unmarried, what Dr. Pragya has said. PCPNDT Act, which is related to documents and confusion in MTP Act and PCPNDT Act. It's documentation, it's monetary authorities, what I will discuss in the next question. Documentations and doctors, harassments, it was not actually harassment. Nowadays, the things are very changed, and now I think appropriate authorities and doctors, they have a good communications and they knows that the more about the documentation. But few years back, it was really very embarrassing. Even I have seen in my nearby places that teams comes and they, seize the machines, they seize the clinics and all just because of doing abortion. And of course, the patients' issues, clients' issues because of poverty. So now next very relevant question. That is, of course, we know that it is a not legal right. We can abort in the certain condition. Yeah. Now that's very relevant. What is understanding of PCPNDT and MTP Acts for OBGYN practitioner? Because most of the time the PCPNDT monitoring teams comes and they do this and they see all MTP documentation also. Are they linked? What it is actually means MTP and PCPNDT? Yes, it starts from Dr. Shamal Seth. Yes, sir.
Those are two different entities altogether. By MTP Act, your prime aim is going to provide a safe abortion services, respectful abortion care, and it gives license to the providers basically. And PCPNDT is basically to check or prohibit the sex selection, thereby altering the sex ratio. So the question of PCPNDT Act in relation to MTP, it comes only when you are acting as both. You are doing the sonography itself and you are terminating the pregnancy. There might be the issues of PCPNDT Act in cases where you are doing the sonography. Now, when you are advising as a gynecologist the sonography to be done just to locate the pregnancy, to exclude ectopic, or to determine the duration of pregnancy before you want to decide whether you are going to do it medically or by surgically. So it is the responsibility of the sonology clinic to maintain all those records that sex selection has not been done. Now, I myself, I have been a part of the NIMC team on several occasions, that I have visited several places. Now, they just need to maintain the Form F. You know, and truly speaking, that does not say anything. That neither this excludes that you are not doing sex selection, nor does it confirm that you are doing sex selection. So, but the government wants, if you maintain the criteria, if you keep your Form F filled properly, you are granted the license to do sonography at your clinic. So that is the thing altogether. PCP is something different, MTP is something different. Relation is only when you are doing both services together.
So, Dr. Shamal, you have told very clearly that it is true. All of us know mostly that MTP Act, which is only to facilitate better implementation and increase access for women, especially in the private health sector. And we all know that it is established in 1971, then DLC is formed, and then now in 21 it is amended. But the PCP Act, we also know that it is for use of only technology to use the ultrasound for prevention of sex determination as well as its disclosure. But it is very mentioned in the government of guidelines that PCP does not restrict access to safe abortion or require monitoring of abortion services. Number one. Number time, it is also written that at time it is assumed that most abortions are for sex selection, but this perception is untrue and not supported by any study or fact. Of course, I have taken from the there is a one guidelines of the government, and this beside that, PCP does not regulate abortion services delivery, documentation, and its reporting. Abortion services delivery is to be monitored under for MTP Act, and both, of course, CMO is mainly their chief appropriate authorities or monitoring authorities, but both team they have a different and they are regulated by the CMO. And so next question comes in this regards, and one PCP team asked, like many PCP concern only those who are doing ultrasound, those who having the machine. If those you are not having the ultrasound machine, then you are not supposed to fill the PCP forms and all. So, but like if you are many obstetricians, you are having the machines, you are having the doing the ultrasonography also, and you are doing the obstetric procedures also. So, Dr. Sneha, if some PCP team and ask and inquire for the MTP data, like she says your PCP data and all, then she says यार आप अपना register दिखाइए कहाँ कितना abortion किया कितना क्या किया. So what you should check for, what you should keep and what you should show them if you have some information about that, Dr. Sneha.
Yes, I think if it is by the appropriate authority, then we have to reveal the data, whatever you have, because if at all there is a suspicion, I'm sorry. I think if there is a suspicion of sex selection or sex selective abortion, I think that is a situation where you really have to clarify with the evidence. So that is a situation. Also, if at all you have a clinic where you have certain genetic procedures, like, then in this situation, maybe you have to keep all this data very carefully, and if at all the appropriate authority asks for it, then I think you have to show or reveal the data. I think that is from my side.
Doctor, do you want to tell something?
May I share some personal experience?
Yes, Dr. Shamal, please.
On last occasion, I had been to Arunachal Pradesh as a part of the NIMC team, and we visited one hospital come ultrasound clinic. And you know, the persons from the NGO team and the women activist team, they are very desperate that if they can find out a single or say silly faults, they are going to seal the message. They actually visit the centers with an intention to seal the message. Now, in a hospital, they inquired and checked in minute details what are the number of deliveries in last 3 years and the sex of the babies. And it was seen that 70% of the babies were female. 70% of the babies were females. But still, just because they did not maintain the Form F properly, machine was sealed.
So, yes, Dr. Shamal, what I have...
what I want to add is that...
Yeah, Dr.
Can I add? Yeah. Dr. Bharti, can I add?
Yes.
Yeah, so basically, whenever some authority comes to you, it is you can tell them that you are not part of it, because MTP is not part of PCP and
Yeah, absolutely.
So we can always tell them that we don't have to tell you the data as per the law. As per the law, we can only give to CMHO because it has got lot of this secrecy and all those things.
Absolutely.
We are already sending them the form 2 and all those things. Form 3 should not be given to any of them as per laws. So we
Absolutely.
have.
Yes,
Yeah,
Dr.
we should be firm enough that it is not part of PCP.
PCPNDT, both are the different acts. One. Second thing that PCPNDT in any form does not regulate abortion services and all. Second thing, whenever some team come for you, some checkup and all, you just see the what papers she has. Even in the next few slides, I will tell you that in the MTP Act, even without CMO letter, no one can check. Even DLC members cannot monitor your facility. So you have to see that what letters they have and for what.
Give that data to only
MTP
people
facility.
who are responsible. We can't give to anybody.
Yes, so you have to see that who has come and for what purpose. If they are come from PCPND team or they have come from the
So is it the appropriate authority?
Yes.
For what they have come. Second thing that I want to share you that these appropriate authority can suspend, cancel your certificate of registration of under the PCPNDT Act or so that is they have authorities. And second thing, they can investigate, complain of breach of provision of act or rules made under this act and take immediate action. He may seek and consider advice of advisory committee on application for registration, complaint for suspension or cancellation. However, the appropriate authority must ensure that recommendation is in line with provision of PCPNDT Act. That is their duty. But here it is also seen that they have all these things that they can check your forms, books, pamphlets, advertisement. They can seal and they have to make a list and they will share it also you whatever they have seized and whatever they are they have a copy both of the persons whose clinics and those appropriate authority both have in the two sets. And there are lots of witness also. And but again PCPNDT does not govern inspection of abortion services delivery. Inspection only extend to machine that is capable of determining the sex before or after conception. We must know this knowledge, first thing. Second thing, we must complete or keep, as Dr. Shamal said, the documentations of both related to PCPNDT also, and we must know that this documentation is required and we are doing, and same for the MTP. I will tell you what is specific documentation you have to maintain for the MTP Act. Now in this way we are coming as the clinically application on this act. So I come to Dr. Guha is not there, na? I think he's not. If he's there, sir, you are there? No. So, Dr. Sneha, you will start this question that how one can start MTP, how site is approved and renewal condition, and can this approved site be cancelled by whom and when?
Yeah. So I think it's not that we are qualified obstetrician gynecologists, so we can directly start, as a new practitioner, or maybe just you have shifted to some hospital. The person has to be qualified, and the indication has to be correct, as which comes under the purview, and the place has to be recognized or approved by the appropriate authority. So it can be a government hospital, either started or approved, maintained by government. It can be a private setup which is approved by the government or the district authorities. So that's how the place has to be recognized. And even if there is, the place is transformed, maybe either it is shifted from one place to other, even the second center has to be once again renewed and the new approval has to be taken. So that's how you have to start with the FTP center, I think.
So we have to basically, as Dr. Sneha has very well mentioned, we have to fill in the Form A, apply, and then request the CMO for inspection. And if only when they are satisfied with the available things, then only they will, the certificate. If there is any deficiency, they will come again.
Okay.
And site re-inspection will be required. So we must know before applying that what are the basic criteria for you. You should fulfill those criteria before you apply.
Okay.
Your degree is one, your all equipment, sterilization, your basic resuscitation tools, your if any complication occurs, you should have all emergency drugs, everything, your registers, what you'll be having. So we have to first make your place ready for inspection and then apply in Form A so that your site gets.
Yeah, I think I just said that the place has to be approved, but everything systematically has to be done, the entire procedure, as Dr. Anju has said. But the district authority, which consists of the committee for MTP approval, it consists of the surgeon gynecologist and the anesthetist, and there should be at least one woman in this committee. That committee should approve the center, considering all the possible, all the recommended.
Yes, Dr. Sneha, once your center will be approved, you will receive this Form B. So once you have got this Form B from CMO office, you have to display it at your clinic. It only then you can start your MTP. But what about Dr. Shamal said, if someone is want to give MTP pill and she doesn't have this certificate, her center is not approved for MTP, can she give, or on what basis she can give? Dr. Shamal.
Can I answer this? Yeah, Shamal, for you it is, yeah.
Very short. If you want to do an MTP in a public hospital, that public hospital doesn't need separate approval provided it has got the required infrastructure. And there are different setup of infrastructures requirement for different trimester terminations, for first trimester or for second trimester. Now, if it is a private hospital, only then it needs that approval from the district level authority. And if you are going to prescribe a drug for medical methods of abortion, now you can prescribe drugs sitting at your clinic. That clinic does not need any approval from anywhere or anybody. But if you prescribe drugs for medical methods of abortion, you need to display a referral linkage certificate at your clinic that yes, your clinic has got a referral linkage benefit to such and such hospital, which is approved for carrying on the MTP services. And that needs to be displayed at your clinic, and then again you can prescribe any drugs for medical methods of abortion sitting in your chamber. That's the only requirement.
Basically, one can give from, if she is eligible provider, meant for medical methods, one has to be according to MTP Act RMP. If she is so, she can give from their OPD, but her OPD should have one linkage to from an approved site that should be displayed, and this certificate should be signed by the owner of the approved site. This is mentioned. And beside that, all the records of pregnancy termination had to be maintained for medical methods also. And now one more thing, Dr. Anju or Sneha, one of you can take that regarding the approval. Of course, who can monitor your sites, or whether it is done sometimes, or how frequently renewal is required for MTP? Yeah, Dr. Pragya.
No, I was asking something else, with regards to that empty pill, for whether, the center has to be registered. I mean, empty pill is something which is, sold over the counter.
Yeah, but you can prescribe sitting in your chamber. Your chamber does not need.
Dr. Pragya, you are absolutely right. It is sold over the counter, which is not the right way.
Yeah, it is an OTC drug. So really,
it is not OTC. It is wrongly given.
No, it is not wrongly given. I mean, it's they are licensed to sell empty pills. I mean, it is an over-the-counter product.
According to my knowledge, there is no license. Even when we prescribe in my own hospital, I have to fill in a complete form, given a register. My medical store can't sell an MTP kit.
No, but I don't have, in the sense, the patient gets it from the pharmacy.
That is illegal, I believe.
No, it is clearly mentioned that the gynecologist has to keep it with us. At least
whatever, that is what I have pointed out in the first question only, that it has to be prescribed by the gynecologist, not sold by the pharmacist, which has been happening in our country, right? Every day more than
has to be given only by registered medical practitioner.
Yes,
no doubt about that.
Not by pharmacist.
We proceed further. There are lots of issues, but it is clear that pharma cannot give it. It has to be given by the registered medical practitioner, and it is according to Act, it is mentioned everywhere. Anyway, so like when it is clear that
can I come 1 second, Bharti? It is very important. If it is prescribed by somebody else and government finds it, there's a prison imprisonment for 2 years for illegally giving these
Yes,
drugs.
yes, but
As
you know
per the law.
that so much of close monitoring is not there, so we have
Yeah.
to create awareness about that, and we
Yes.
have to, of course, we have to raise this issue. This is important
Clarify
issue.
my doubt. That's why I was asking. I want to clarify my doubt.
I think Pragya was right. Because initially when the product came in, it was supposed that the doctors are supposed to insert the tablets vaginally or say ask the patient to take the medicine orally in the clinic itself. That was the initial concept, but that is not being followed, or that is not being maintained as a rule. In fact,
So if we,
that should be followed, sir. It is not maintained is not the right thing. It should be followed.
yes, now that's why we are discussing in this panel about the act and about the laws, what actually even our clinicians and our doctors, we are not very much, it is not written in some one book. So we are also not very much familiar. So I am telling you, first thing, one clinician, as she do post-graduation or anything wants to do obstetrics, one has to keep this form A. This is a form A, which is site approval application form. And as Dr. Anju or Dr. Supriya Sneha has told that they have category whether in the first trimester approval, second trimester, and in this form it is written that what facility is required. Like in category table and etc. In category B, where you are in the second trimester abortion, you always need operation table and surgical facilities. So that is clear. Once your site is visited, you are getting form B, then you are very safe that you have approved place where you can do MTP, and for what you have taken approval either up to 12 weeks or onwards, it is on you. Then you can do MTP for only till that gestation also, except in certain exceptional conditions for patient life saving. Then this is, you all must know that there are many confusions, because in last 3 years my MTP tenure, whenever I always try to create a meeting between CMO persons and our society's leaders, and then lots of communication gap was removed, and it is comes many places they CMOs and their teams were in impression that they have to do renewal of MTP site also every 5 years. Then it was then that it doesn't require renewal till there is some complaint or there is some insufficiency on some inspection. First thing, PCPNDT every 5-year renewal is required, but not for MTP. Second thing, doctor conducting MTP
But
are
Dr.
not
Bhatt, they are
certified
still
by
asking for
DLC.
it. Most of the states, they are still asking for renewal after every 5 years.
वो से different places में, but actually according to Act for MTP renewal is not. Till they have upgrading is their facility, or there are some.
I think whenever their certificate is issued, initially they give it, temporary, and once it is made permanent, you don't have to renew.
That is the different
No,
system. If they have
Dr.
given you
Sneha,
provisional,
Dr. Sneha,
if
I
they
just
have
want
given
to,
you provisional, but now
Dr.
normally.
Sneha, I just want to point out, Sony Hospital opened in 1986. Still, I had to get it renewed at least 3-4 times.
Madam, that's why I said in every year, in every place in the country, there are something different.
There are different laws by their local teams, which we
According
can't,
to law, actually
can't
doesn't.
decide.
But if CMO seems he can come for any time for monitoring, and he can cancel or she can cancel. And it is also that CMO is authorized to inspect the places approved for conducting MTP to verify whether it is conducted under safe and hygienic condition. And DLC in appropriate cases offer affording opportunity to owner may suspend or cancel your certificate of approval. And then again owner may file a review application within 60 days to the government against the suspension. The government, after giving the owner an opportunity of being heard, may confirm, modify or reverse the order. So DLC members are not authorized to conduct inspection without permission of CU. So that was I have taken from Government of India's guidelines. So you all must know this. Now with all this background knowledge, we come that one patient, she's a 24-year-old having 2 issues. Now she's 7 weeks pregnancy. You come for termination of pregnancy, as she said that she was taking the contraception, but it is failed. Now Dr. Pragya, how you will proceed? जैसे आपका patient आता है, what first line you will do, what you second line you will do, what things you will keep in your checklist, and how you will proceed? Yeah. Dr. Pragya?
Yeah. Thank you. Actually, first of all, we need to check her LMP, her last menstrual period. Ensure that, but she's saying 7 weeks, whether she's actually 7 weeks. Sometimes, they say first trimester, but by the time she comes, she may be 16 weeks, 17 weeks. So you need to examine the patient, and if there is a need, you need to do an ultrasound. So And of course, after that, well, of course, if she fulfills the criteria, then we need to discuss about the methods of MTP. Really, I mean, at present, it's not the era where we just force something on the patient that no, you need to go for a surgical termination. If she's, if she's between 6 to 9 weeks, we need to give her the options of medical versus surgical termination. So let her know, and the various methods of medical termination. We need to discuss about everything. Need to counsel her about the pros and cons, side effects. Sometimes, with them, because especially with medical termination, we need to tell them she needs to have a follow-up scan to ensure that it's a complete one. So those kind of things, we need to tell the patient. And
I think, Dr. Bharti, in addition to what Dr. Pragya has said, first and foremost question I will ask Para 2, whether she has both females and whether she is really 7 weeks, how she, Dr. Pragya has said. I think we have to rule out here the possibility of sex selection. That is what the first point from my side. And then, of course, secondly, whether she has really used some contraception and whether it is because of contraception failure. And thirdly, the exact duration of pregnancy. Yes.
Examine, because it could be an advanced pregnancy and she could have
Yes, exactly. So thirdly, what is the exact duration by her last menstrual period, as Dr. Pragya said, and we would like to confirm whether it is really so. So maybe we go for ultrasound for and clinical examination and ultrasound for documentation as well. I think that is, and once everything is ruled out, then we decide what will be the method of choice for termination of pregnancy and whether she is really willing to use post-abortion contraception, whether it is permanent or temporary. I think all these things.
So very truly, Dr. Sneha and Dr. Pragya has cleared. This is just for the audiences, one line summary. This I have put this slide I have bought from the government website. And UP government has, and they have very clearly have made this chart. Once pregnant women come to you for MTP, first thing you do confirmation of pregnancy, second thing gestational age, third thing identify indication of MTP, whether it comes in your indications or not. Fourth, you discuss the methods of different MTP, medical and surgical, and counseling. I will come next slide on the counseling. Then you get obtain informed consent of women on the form C. Then you complete the form 1, and if it is more than 20 weeks, then till 20 weeks 1, and after 20 weeks 2 RMP sign. Then you provide her MTP service. Then form C and form 1 has to be placed in a sealed envelope. Secret and serial number should be written on that envelope. Complete form 3, admission register, and all form to be kept in custody of head or owner of institute and should not be open for the routine inspection. Only the CMO has authority to inspect these confidential documents. Strict confidentiality has to be maintained, though it is very difficult, but last time we all have discussed, but whatever we can do, we have to do. Then form 2 is to be submitted to the CMO office every month. Even in the case of medical abortions, all the above form has to be filled, all records to be preserved till a period of 5 years from the last entry in the register. In the admission register, the serial number of MTP in that hospital clinic for each year will restart from serial number 1 every calendar year. These all slides are in FOGSI Focus MTP. You all can have from the FOGSI website. So this was about the approach for the on this slide, I always share that comprehensive abortion care. All of you have emphasized on the post-abortion counseling, pre-abortion counseling, clinical assessment. So only uterine evacuation is not MTP. You have to, till we will not handle all these issues, till we cannot avoid the abortion-related morbidities. Now, Dr. Shamal says, counseling for MTP, because we always ignore this part. We think that it will be done by our subordinate and ये तो patient को पता ही है, तो सबको पता है. So who should be done, why, and what to tell? Most important 4-5 lines.
Actually, whenever you give them MTP services to any lady, you should always thorough counseling regarding the purpose and indications for which she is going to terminate the pregnancy and the methods you are going to adopt for the termination of that particular pregnancy, whether it is medical or by surgical, pros and cons of both the methods, whether the possibility of failure, what is the possibility of requirement of check curettage or a repeat DNA method. All these things you need to discuss, and as Sneha rightly pointed out, post-abortion contraception has to be dealt with very significantly, and this is the golden opportunity that you have got the right and to persuade the patient to choose some kind of abortion. But the problem with this availability of the drugs or medical methods of abortion is that they are very reluctant to use contraceptives. Very frequently, you will find patients that I have taken the I pill. I have taken an I pill like this. So they are very educated about all those taking I pills. Or once you have prescribed the medical methods of abortion, how to take the pills, they repeat to take the pills with your prescription on several occasions. And it is not uncommon to find few of them coming back with an incidence of incomplete abortion, with a prolonged period of bleeding. So all these things you need to discuss, that even if I prescribe a medical methods, you need to come for follow-up visit, preferably after 1 week, mandatorily at this second week, and thereafter according to the events that which follow after the intake of the medicines or application of the medicines in the vagina. They need to be counseled and educated. And if there is any problem, suppose in the midnight she is having severe pain or huge bleeding, on few occasions, although very rarely, you may need to admit a patient for an urgent evacuation. So all these things you need to discuss. You must give your contact number or the contact number of the hospital where you are going to give the emergency service. It should always be given.
So, like counseling is what I feel is a very important part. I have, everyone should give emphasis on that, and it is very mentioned in the all government of guidelines. It is, and whenever you are doing the medical method, then you can have a counseling as well as you can start the contraceptive methods when you have started the misoprostol. And beside that, one very important message from the government of India guidelines that you have to assure the woman that she will not be refused MTP if she will refuse for the contraception. And then you wait for the opportunity to counsel again and again till she adopts. So that is the very clear. And now ultrasound, we all know that it is not mandatory, but whenever it is required, has to be done. It is and very approachable diagnostic method, but of course has to be done the PCP NDT Act. And lab investigations, we all know now come to Dr. Anju Soni. What is special about the consent of the MTP and how it should be taken? Yeah.
First thing, whenever you take a consent, if the lady is less than 18 years, then we have to take the consent of either parents or a responsible guardian. Otherwise, we don't need to, we can take the consent of the woman herself, married or unmarried. It is not mandatory to take the consent of the husband or the guardian. Secondly, we have to tell her about whole procedure, that you know what procedure is, that is a part of counseling actually. Then basically in
where
consent,
do you take the consent, which form that?
Yeah, it's in Form C. It's in Form C. Yeah.
Yeah, that we have to say that which form we have to take the consent.
We have to take the form in Form C.
But Anju, what you said, below 18 years consent from parents or guardians, but under FOGSI Act, you
Yes, the question is
from the police.
Yeah.
That is the main problem, because she is less than 18 years. First thing you have to inform the police.
Whether she is married or unmarried, if she is a minor less than 18 years, it has to be informed to police. We do not need permission for MTP from the police, but it has to be informed. And then with all the formalities, we can go ahead with the termination of the.
That is the query posed by one delegate also. So I'm sure now she got her answer. Inform and then you can proceed. But you should have that copy that you have informed the police.
If she comes with the father,
even then
there is no question with whom she comes and whether she is married or unmarried. If she is under 18, then that comes under FOGSI.
FOGSI Act. That is the between FOGSI and MTP Act. This is the main problem, because FOGSI Act does not realize that gray area of early marriage in India. If she is less than 18 years, even if married, comes with husband, you have to inform the police, because it is considered as statutory rape in India, according to FOGSI Act.
That will come in one question in just next slide. So thank you, Dr. Lakshmi Madam. So it is clear that just I want to emphasize that whenever you are doing MTP, please keep your on table Form C and all documentation so that you can fill that. And if it is less than 18 years, then of course guardian consent is important, but less than 18 years, FOGSI Act has to be kept in mind. Form C, this consent form, please have a look on it. This is very important. Beside that, other consent like this woman is high risk and all, so you can take separate consent.
Dr. Bharat, Bharti, I would just make one comment here that most of the clinics, they take the separate consent and fill this consent form. But here on this consent form, the woman has to sign herself. That should not be missed.
Definitely. Even on that, separate women can attend, but here it is.
Yeah, but here it's a must.
This should be completed. This should be completed. Then again, I just next in two talks, the clinical R part will be discussed. But I just want to tell you that Government of India has very good follow-up card for medical method of abortion. Those who are not having, please have this. It has all 15 days, all complete information, as well as this is very good. And first, second, third day, what you have to do is a very clear guideline. There are 3 visits minimum are required for medical methods, and one was first what you have to do on the first visit, what you have to do on the second and third. I will share this PPT those who need it, and it would be available. So that is about the consent. And now finally, what documentation have to maintain during MTP? Any one of you, Dr. Pragya or Dr. Sneha, any one of you want to tell? And what is the differences in documentation according to MTP Act amendment? Who is volunteer to take this question?
Yeah, we have to keep
Yeah,
all
you
the
go
3
then.
forms.
Yeah,
We
please.
have to take all the 3 forms. We have to take form Form C, as well as maintain a register which has got where we have to maintain all the details from her address to her age to her, all the details, and that register has to be secret with the secret number, and it has to be for a year. The whole year record has to be sent to the CMO, and that record we have to maintain for 5 years, and then if we don't maintain it, then no problem. But for 5 years, we have to maintain the record, and all the form 2 has to be sent to the B has to be sent. Form 2 has to be sent to the government, and form 1 has to be kept with us.
If I can add something, I think the form I first.
I will differ with what Dr. Anju said. You need to send this form to the CMH within the first 7 days of the next month. Every month you need to send this.
Yes.
It's not at the end of a year.
No, I'm saying the whole thing you have to send the record, the whole record. Sir.
Yes, you need to send within the 7 days of the next month.
Anju, in Maharashtra, we
next month, I'm saying for whole year, you have to maintain for the whole year. Then again, you start with the numbers for next year.
You have to capture
what she means to say, I don't know whether she means to say that you start new register from January. That is okay, but whatever information we are maintaining,
that has to be sent within a week. Like we report for the birth, it has to be reported very early.
So we take it as first 5 days of the month. So before 5th of every month, we have to submit the data.
That is monthly, and for the other things, the form has to be sent within 7 days.
Regarding the forms, Dr. Bharti, should I tell you?
I am telling you that in the summary for all audiences who are attached to this webinar, that what these are the different documentation. If you start from very beginning, first thing form A, that is the site approval form. Form A, जिसमें कि आपको अपना site approve कराना है. Second thing, form B. This should be at all of you have this display on your clinic. I know many of we don't have, but if we don't have, we can get it from CMO office. Even if we earlier we are registered and we are misplaced it, even you can get it. It is safe that if you have this display on your site, because if some mishappening occurs, if it is displayed at your site, then you are very much safe. Second thing is form C, consent form. We all have discussed that all consent. This is very important medical legal document. Anywhere in the court and all, this form is very important. So this should be definitely get signed by the persons, and it should be with you. Then come form 1, that is RMP opinion form. Till 20, this is the form till 20 weeks. Now you can only need the one RMO sign, and 20 to 24 weeks. 20 to 24 weeks opinion of form of RMP. This is form E. This is new release, and they have different indications A to G. So where you can require to do MTP after 20 weeks of gestation. So like survivor of sexual minors, change of marital state, women with physical disability. So these indications are given by the in the MTP Act amendments, where you can terminate the pregnancy 20 to 24 weeks by sign of 2 RMPs. So this is form E. This is the separate form. This is the newly released form. Then you have form 2, but you have to send at end of every month by owner to the CMO office. And then this is the admission research. This is a very important form.
So now it is 16 column.
little
Dr. Bharti.
columns change in the admission 3, form 2 and 3 in the new after MTP Act amendment. This form is a very important form, and I tell you that this is a confidential document and is not open to inspection by any person except under the authority of law. Has to be kept in safe custody. No entry of MTP then shall be made in any case sheet, OT, registers, follow-up card on any document or register other than the admission register maintained at the facility. Admission register need to be preserved for a period of 5 years from the date of last entry. There is no requirement of recording sex of abortus in the admission register or any other record. So, and this is the, I have already discussed you what are the important indication, 20 to 24 weeks, the special categories where you can terminate the pregnancy with opinion of 2 RMPs.
And form D has to be.
This is one other form, that is form D. Here, this is the beyond 24 weeks when you need termination. Then this is the form where the medical board give you opinion whether it is allowed or denied. So these are the different documentation. These all. If any one of you wants it, you can get through any FOGSI websites or FOGSI person request or MTP committee request, you can get it. Even my PPT is available for all of you if you want. So finally, mandatory documentation under the MTP Act, Form C, Form 1, I have already told you, opinion form till 20 weeks, one form, 20 to 24 weeks, one form, and beyond 24 weeks, it is another form. Then Form 2 and Form 3, this is a common for all. And this is follow-up card, what I have done, this is the important documentation we all must have in our hospitals in the printing form or available so that whenever patient can, we can use it. Now, one question from Dr. Pragya. Do missed abortion, incomplete abortion, they have to be fulfilled MTP Act protocols and forms? Pragya is there?
No, we don't know. We need to fill.
So any one of you can take. ये confusion रहता है कि बाहर से patient pill खा के आया तो अभी क्या करना है उसका form
No need. There is no need of filling in these forms.
हाँ, if patient
It doesn't come under MTP.
Yeah, it doesn't come under MTP Act purview.
If she has already efforts and done, so it would become in incomplete abortion. So spontaneous, inevitable, incomplete, miss, none of these come under the purview of MTP Act. So documentation is not required, not Form C consent is required.
That is what doctor has pointed out in his initial discussion only, that lot of people are avoiding MTPs because they don't want to fill in the form and they make it as incomplete or inevitable. Sir, you have pointed out, Shamal sir.
Of course, we know all these things.
Yeah,
we write the facts and they say so. That come under the not in the MTP. So I have already discussed who can provide medical methods. Medical method, what are protocol for safe when called violation of MTP Act. So कब Shamal sir कब कहेंगे violation of MTP Act? आपका तो एक chapter है FOGSI focus में violation of MTP Act पे पूरा.
Yes, I wrote that chapter. So any of these steps which are required to be fulfilled by the MTP as per the guidelines of the MTP Act, suppose it's performed by a person who is not a qualified provider, it's being done at a place which is not recognized or approved, or it's done by a methods which is not approved, and the mandatory documentation and reporting departments, all these things are not maintained or followed. So all those will come and say, suppose without consent you have done a procedure of MTP. So all these will come under the heading of violation of the MTP Act, and the law is very strict these days. One can have an imprisonment up to 7 to 10 years if you do not follow up the protocols of the MTP Act.
So that is very true. So this is very important slide we all must know. No sense or ignorance is not excused at all. आप कितने भी अच्छे clinicians हैं, whatever you are doing, but if you are not fulfilling the protocols, then definitely you would not be accused. So these you all should know that whenever you are called for doing MTP, you please see whether that place is approved for the MTP or not until how gestational is. Second thing, you check yourself whether you are allowed for that MTP or not. Second thing, and third, you have to fulfill all these forms. Consent, whether it is taken on the Form C or not. RMP adequately signed or not. Form 2 and Form 3 is filled on. Then the most important thing is whether it is within gestational limits or not. Only then you will get protective cover of the legislation, only when you fulfill the above mentioned criteria. And if it is not so, then you can have imprisonment 2 to 7. Yes, sir.
300 to 316 with different forms of punishment for different kinds of faults.
Yes. So we must remain very careful. So now this is the one Dr. Lakshmi has a very important issue. So this is anyone can take that 16-year girl come to you with 10 weeks pregnancy, and she is with her parents and she wants to termination. So what protocol you have to follow?
I believe we have already discussed.
Yeah,
Yes, we already
discussed this.
discussed.
We have already said that
Consent of the
whether
guardian.
married or unmarried, because she is less than 18 years, this case falls under FOGSO. This only we have to take her documentary evidence for the age proof, and then we have to mention that she comes under this FOGSO, and it has to be informed to police. As we have already discussed that we do not need permission for termination of pregnancy, but we have to inform police and go ahead with the
Yes, so
formalities.
basically we are not obligated to file FIR or
Yes.
conduct investigation. We have to just tell information, and duty is to only inform the authorities when providing services to a minor. And legal proceeding, if any, can continue simultaneously. One should do their clinical services. So that was about the always we have you all be together done Surakshit Ho Kar Paat Beti Bachao ke saath. So what are the important the last slides that what efforts? Yeah, Pragya, you want to tell
The
something?
patient's guardian also has to be told that you are going to inform the police because she's a minor.
Yeah, yeah, of course.
Yes, in,
Because FOGSO Act, you have to tell them, even if they are pressurizing you not to inform.
Ve-
You are legally
exactly.
bound. Otherwise, the healthcare provider is
It is-
for imprisonment.
It is not mandatory to inform the guardian. It's a procedure to be followed, so that we have to do whether they say yes or no.
Oh, yeah.
Yeah.
It is the act.
So
Just the
definitely we
courtesy
have
you
to
can inform them.
inform to the police. That is, and we must keep receipt copy with us only. Then it is useful.
Yeah,
So
yeah.
the nation, of course, by this long discussions, we come to the conclusion that there are only these 4 important issues where we have to work and we can avoid, we can keep ourselves safe. That is the counseling. That is the first and foremost and very important issue. Then documentations and improving our skills. Of course, whenever patients come to us, even for safe abortion services. So nowadays, lots of clinical challenges which we will discuss in next 2 lectures. So and act know about always all updation about the acts and whatever day to days. I have already this approach. I have already summarized this. And the last, this is nowadays Government of India women-centered approach as per Government of India that devote adequate time for counseling, maintain privacy and confidentiality. This is very important. Wanted things from us. Use safe technologies, MBA, EBA, MMA. Follow standard protocol for infection prevention, pain management, and management of complications. Offer post-abortion contraception. Provide reproductive and other health services, RTI, CI counseling on sexual violence. This is very important. Is tailored to a woman medical and personal need. So this was all about the important issues related to clinical applications of MTP and PCP and DTR. And this whole documentation is available on the FOGSI website. You can get it. And this is again the national policy. Please don't jeopardize the safe abortion services in preventing sex selection. And this was all we together done. FOGSI has done lots of efforts for last so many years. This is the WHO and all international things for the providing the safe abortion services to our women. And in our countries, as we have already initiated lots of things from very beginning, 1971 we were among the first few countries. So this was in the and that's by because of that efforts we today had reached that we have got MTP Act amendment. We have better things, better scenarios in the if we compare for 10 years back when PCP and DT acts in our hospitals and when we documentation maintains, and nowadays we are in the better position. So definitely this would be done good, and I think one day come when safe abortion services will be available to each and every woman, and this 8% mortality will be zero when no woman will die because of abortion related causes. So now Dr. Lakshmi Shrikhande and is with us, so please
Before you end, Dr. Bharti, we like to thank Dr. Lakshmi Shrikhande for thinking out of the box, always thinking out of the box, and very
She is very
important
innovative.
topics which are, you know, important for day-to-day practice and every practitioner. Yeah.
Madam is very innovative, creative, and you all are very given very important and good input. In fact, I think that those who are attended, they will definitely. And there is one or two questions I have seen in chat box. One question was,
There
now
was one
approval is
question
up to 12 week or up to 24. Whether got approval up to 20 week before amendment now means 24 week, no need for re-registration, but you need to get your form.
Bharti Richa Sharma has answered in the chat box.
Richa Sharma ने किसी को बताया? हाँ,
Let
ठीक
us
है.
finish the talks, and if time permits, you can answer the questions, because I think everything has been covered in the panel discussion.
No, there was one question about someone had asked about Form F. So I could answer that. I mean, that is related to PCPNDT. And someone asked whether, you know, if under 11 weeks, one has to fill Form F. So, well, any pregnancy, any prenatal diagnostic procedure, whether it's invasive or non-invasive, we need to fill Form F. So that's to do with PCPNDT. Dr. Madhu Singh had asked that question, you know, so under 11 weeks, any kind of pregnancy, I mean, well, any procedure that you're doing in the antenatal period, whether it's invasive or non-invasive, you need to fill Form F.
So I think big thank you to all panelists, Dr. Lakshmi Madam, Dr. PK Shah sir, and all that you have given a good interactive discussion on the MTP Act and PCP and DT Acts, and I think queries will still exist and we will continue to solve it. So now we come, thank you very much, and now we come to the next session. That is a very important talk by Dr. Parikshit Tank. Dr. Parikshit Tank is here. I think we can see him. Dr. Parikshit, you are there?
Can't see.
Dr. Parikshit. I see.
I could answer a question which someone has just posted in the chat box.
Dr. Parikshit.
You can invite Richa by then.
Dr. Lakshmi, someone had asked a question, so in the chat box just now.
I'm not able to see Dr. Parikshit. Dr.
Dr. Lakshmi saying invite Dr. Richa and continue the program.
Yeah, invite Dr. Richa.
Okay, I invite Dr. Richa.
Yeah.
Okay, so now we have another session on the topic. Dr. Richa Sharma, we all know that she is a currently MTP committee chairperson, and she is a professor in University College of Medical Sciences as well as national corresponding editor in Jogi. And we all know that how good she is doing in the MTP committee, and she is very active, dynamic, young speaker. So I invite Dr. Richa Sharma for her talk, that is abortion in difficult cases. Dr. Richa, you are there?
Yeah, a very good evening, everybody. Thank you, Bharti Madam, for the kind introduction. And thank you, ICOG. Thank you, Dr. Lakshmi Shikhande Madam, for giving me the opportunity. And my regards to all the respected seniors, Dr. PK Shah sir. My regards to you, sir, and regards to all the seniors who have logged in today. So I will just share my screen. Actually, my talk was interconnected to Dr. Parikshit Tank, who was supposed to cover the second trimester MTP. But okay. Okay, so I hope my screen is visible to all.
Yes, Richa. Yes, you can see.
Okay, so once again, thanks and regards to ICOG. So I will be speaking about Surakshit Garbhat in difficult situations. Now, in the previous panel, we know what is a Surakshit Garbhat or a safe abortion, as in the person who should do the MTP should be qualified, and there has to be some indications which has been laid down by the government of India, and then place has to be approved for MTP. So that is Surakshit Garbhat. Now, even moving forward also, now government has also supported in such a way that now there is a government public national health insurance funds are also there. That is in terms of Ayushman Bharat and employee state insurance. So now the package is there for the surgical abortion, which is somewhere between 15,500 for surgical abortion and 1,500 for medical abortion. Now, medical abortion, this package includes consultation as well as the ultrasound. So this is for the public patients. Now coming to the difficult cases and how to do the Surakshit Garbhat, I have just compiled the series of 7 cases, and then I will discuss how to go about it. Now this is one patient whom you decided to do the surgical MTP, that is a electric vacuum aspiration, and she came at 11 weeks and she had undergone the LEAP 2 years back. Now the patient who undergoes any surgical procedure on the cervix or they have a forceful dilatation, now we have to be very careful. One thing is that they may be having the cervical stenosis. Now what is cervical stenosis is that when the diameter is somewhere between 1 to 2 millimeters, and stenosis can occur at the level of internal os as well as external os and anywhere into the cervical canal also. So the risk factors are previous surgeries, conization, LEAP, or even Manchester's, DLCs, and even the congenital also we can find the cervical stenosis. So whenever we have such kind of patient, we have to prepare ourselves beforehand so that whenever we are doing the surgical termination of pregnancy, we don't fail. So of course, there are pharmacological methods. All of us know that is a mesoprost or the osmotic dilators now, that is a dilapen, or mifepristone can also be put, and then carboprost. So these are the various pharmacological methods, but then story doesn't end here, because in these patients who are having the cervical dilatation, we have to have something else also. That is, now if we are planning to use carbon cannula or a easy grip cannula, now these cannula all are color coded as you can see in the picture. So the smallest one is yellow color, which is 4 millimeters. So when the patient is having cervical stenosis, this even 4 millimeters cannot not be negotiated. So we should have the lacrimal probe, and now the dilators are also there. And the diameter is from 5 mm to 1.2 mm. So in the cases of cervical stenosis, this can easily negotiate, and it will be best if you have the ultrasound guidance. Even the Foley's catheter, what we have, the smallest, that is a 5 French, which means the diameter will be 1.7 millimeters. So even that can also be helpful. So we should be having all these things whenever we are approaching such cases. And after that, now dilapen, now they are also there, and the small diameters, 2 to 3 millimeter diameters are also there. So you place it into the cervical os and they swell up and they increase the cervical dilatation. But then you should also have the hysteroscopy set with you, and micro scissors and surgical electrodes also with you. That could be the last resort in the cases of cervical stenosis. Now, anesthesia and analgesia in such patients is very, very important, because we all know otherwise a patient who is a low risk and you are wanting to do a vacuum aspiration. So in that case, just an oral analgesic or a paracervical block, or maybe a combination of paracervical and conscious sedation is sufficient. But the patient who is having cervical stenosis or who is a nulliparous woman or anxious woman, in that case, you should have the general anesthesia given to the patient. And cervical stenosis, certainly here we will be using the general anesthesia. Now, a quick revision about the paracervical block. You can see the video also. Now, usually we have to take 1% of lignocaine in 22 gauge needle, and then you inject one at 12 o'clock or 6 o'clock, where you are wanting to hold the cervix with tenaculum so as to stabilize it. And then next you have to inject at 4 or 5 sites at the depth of about 1.5 to 3 centimeters. And then, but before you inject the lignocaine, you always has to aspirate it so as to avoid any intravascular injection. And the maximum dose of lignocaine recommended is 4.5 milligrams per kg per dose. So now coming to the other case, now this patient, now other patient who is 18 years old, and she is married, and she comes at 8 weeks gestation, and she wants to have MTP because she is studying, and this pregnancy was a failure of contraception. So now in this case, now always whenever we take up any patient for MTP, always we have to check the ID card. Now ID card is very important so as to know the name and the age, confirm the age also. Now this patient, although 18 years, we have to report to the police. Why? Because when she conceived, she was less than 18 years, because now she is 8 weeks. So according to the FOGSI Act, we all know that a minor girl who is less than 18 years, she just cannot give the consent for sexual intercourse. And pregnant minor girl, if she is married or unmarried, she will be considered a victim of sexual assault. So in such cases, always we have to make the medical legal certificate. And but we should not insist for the FIR, because although she is minor, but she is happy in the married life. But informed refusal for FIR should be taken. And we have to explain to the patient very clearly that we have to inform to the police, MLC has to be made, and this is just a routine paperwork so that they should not get worried. And MLC and FIR both are different. We have to tell them, because MLC is just recording a case, whereas FIR means a complaint is lodged, and then the police case, court case, and then punishment can happen. So we have to counsel the patient in such a way. Now this patient, she is in the first trimester. Now how to do the MTP in first trimester is very important. So first trimester, we have two methods, that is medical method or surgical. Surgical could be manual vacuum aspiration or electric vacuum aspiration. And second trimester, again, medical method or dilatation and evacuation. Now, whenever we say MMA, so MMA typically refers to the medical method up to 9 weeks. So now the regime which has given by the WHO also, which is a very good regime and easy to remember, is that if the gestational age is less than 12 weeks, we have to give 200 milligrams oral mifepristone. And after 24 hours, we have to give the misoprostol, that is 800 micrograms. That is buccal, pervaginal or sublingual. This is a single dose. And then the new regime which has been added by WHO Abortion Care Guideline 2022 is that even the letrozole can be used. That is 10 milligrams of letrozole you take orally for 3 days. And then on day 4, misoprostol is given, that is 800 micrograms. And it has a very good result, and it is safe and effective option up to 14 weeks. Then after 12 weeks, now if you want the termination, then again, mifepristone is 200 milligrams oral. And then after 24 hours, misoprostol, that is dose is 400 micrograms. And you repeat the 400 microgram dose every 3 hours. And now there is no maximum dose, because earlier there was the 5 dose was maximum, and now there is no maximum dose. You have to decide according to the PV findings. Now coming to the Government of India guidelines, they have split the regime, that is up to 7 weeks and at 7 to 9 weeks. So up to 7 weeks, they have advised the mifepristone, that is the same dose, 200 milligrams. And then after 24 to 48 hours is misoprostol, 400 microgram is the dose. And then 7 to 9 weeks, again, mifepristone is 200 milligrams. And after 24 to 48 hours is misoprostol, 800 micrograms. So this regime is very much effective, and it is about 95 to 99% is the success rate. But then we have to rule out the contraindications, which means the patient should not be anemic. Hemoglobin should not be less than 8 grams. She should not be having the uncontrolled hypertension of more than 160/100. There should be no severe renal, liver or respiratory disease or uncontrolled seizure disorders or any allergy or intolerance. Now, whenever we advise a patient for misoprostol and mifepristone regime, we have to explain to them, and we have to give them an extra tablet also, so that if the woman, she vomits within half an hour of intake of misoprostol, she has to take it again. And we also have to explain to the patient that if they do not have any bleeding after 24 hours of misoprostol intake, that means it is a method failure. So again, either we can repeat the same regime or vacuum aspiration is the best alternative. And this is the MMA card, that is the Government of India MMA card. We can actually also devise our own card. So what is more important is that whenever we are giving a MMA means a medical method of termination on an OPD basis. So we have to clearly write the name of the hospital, the doctor who is treating, and also the contact number, so that at the time of complications or any problem, she can contact. And here we have to clearly write the day 1, when is the day 1, that is a mifepristone intake, that date. Then day 3 when she comes for misoprostol tablet, and day 15 when she comes for examination. So we have to tell her clearly what all dates she has to come. and then the phone numbers. And we have to tell the warning signs also. So whenever we give the MMA, we have to counsel that patient may be having a spotting for about 8 to 13 days. But then if she is having excessive bleeding, and if she is soaking more than 2 pads per hour for more than 2 consecutive hours, she has to report back. Otherwise, a small amount of bleeding and spotting for 1 to 2 weeks is normal. And if she is having a nausea and a vomiting or a fainting attack or a severe abdominal cramps, which is persistent also, she has to come back. So these are the warning signs we have to explain to the patients. So now coming to the another case, now that is a heart disease. Now we always have a dilemma whenever we get a patient who is having a heart disease. Now whether to continue the pregnancy or whether to offer the termination. Now this is one patient who has come with 9 weeks of pregnancy and she was diagnosed to have peripartum cardiomyopathy. And then now she has conceived and she doesn't know whether to continue or whether to abort the child or then. So then she came for the consultation. So now peripartum cardiomyopathy, we all know it is a myocardial disorder and wherein the heart muscle is structurally and functionally abnormal. Although it is a rare, but it is a potentially lethal complication of pregnancy. And the incidence is about 1 in 3,000 live births. So what is the criteria of peripartum cardiomyopathy is that the onset of the heart failure or the signs and symptoms, they will appear towards the last month of the pregnancy or within 5 months postpartum. And the left ventricular systolic dysfunction, which is measured in terms of ejection fraction, will be less than 45%. Or the left ventricular end diastolic dimension will be 2.7. And there is no evidence of any pre-existing heart disease. And there is no identifiable causes of heart failure. So in such patient, whenever they deteriorate and have a heart disease, we should think that they are having the peripartum cardiomyopathy. So usually a peripartum cardiomyopathy patient, they have the full recovery after 2 months and the ejection fraction also becomes normal in more than 45%. But then risk of recurrence also is there and it is 20%. Now this patient who has again come back with pregnancy and she had a peripartum cardiomyopathy, or for that matter, any patient who comes with heart disease, it is always better to score them. And that is WHO pregnancy risk classification. So we should see which class it falls, class 1, class 2 or 3 and 4. So class 1 and class 2, the patient, they have small increased risk of morbidity and mortality. But class 3, it is a relative contraindication for pregnancy and class 4 is the absolute contraindication for pregnancy. So we should see which category they fall. And now this patient, peripartum cardiomyopathy, belongs to class 4 and also has a residual impairment of ventricular function. So here the pregnancy is contraindicated. But then there are few patients where they have a precious pregnancy and they want to continue the pregnancy even if they are in class 4 or class 3. So in that case, we should have the multidisciplinary approach and we have to counsel the patient about the mortality and the morbidity. And all the risk has to be explained. And it is found that the risk of heart failure, arrhythmias is very high in such patient, up to 40%. And the mortality is up to 50%. So the patient has to be counseled if at all they want to continue the pregnancy. Otherwise, termination is the best choice for them. So this patient now we had explained and certainly she opted for termination of pregnancy. But then again, the question is whether you want to terminate by medical method or a surgical method. So there is no published data as far as the medical or a surgical choices goes for the heart diseases. So, but if you want to give the medical method of abortion to such patients, you have to remember that the MIFI-MESO, they have the risk of causing the tachycardia, hypotension, infarction, and stroke. And then bleeding can also be continued up to 1 to 2 weeks. And these patients, we have to protect them against the pain and the infection because they will precipitate the heart failure. So seeing all that situation, we always suggest that surgical abortion in the heart disease patient is always advisable. So that because it is a hemodynamically more controllable situation. So that is one thing. And then going on to the other case now is the other patient now who presented at 25 weeks. And she had a GCA baby and encephaly was there and central placenta previa. And she was previous cesarean also. So now again, the dilemma in such patient is that whether you want to take up the surgical termination, hysterectomy or anything. But see, patient, that is very simple, doing the hysterectomy and doing the MTP. But the patient who don't have the living issue, as this case, she doesn't have the living issue. So we have to conserve, we have to preserve the uterus as far as possible. So how to proceed in such cases is that 25 weeks or so, of course, we have to take the medical board approval first. That is after 24 weeks. So, and then ultrasound is very, very important in such cases. Previous cesarean section and having the central placenta previa, we have to rule out the placenta accreta. And then whenever we are taking the termination of such patients, it has to be in the tertiary center or a medical college where we have the support system. And then 2 registered medical practitioners have to perform the MTP. Their 2 RMP's name has to go. And then we have to have the blood products and the anesthesia facility should be there. Now, when we are doing the MTP in a complete placenta previa, maybe in 2nd trimester or 3rd trimester, our aim should be vaginal delivery as far as possible. So accreta has to be ruled out because it is very important so as to plan the management. Now, coming to the data and coming to the recommendation, there is no clear cut. The data is very limited, whether you do the dilatation and evacuation versus medical induction or using osmotic dilators in such patient. It is said that in 1st trimester, usually the placenta previa, they can abort in toto, but in 2nd and 3rd trimester is very important. So there are few papers wherein they have used the uterine artery embolization or even the feticide, which was done. And then they had undertaken the patient for surgical evacuation. And then they reported that the hemorrhage was much lesser. So this was another large study where they had given the pre-induction feticide was done with the help of potassium chloride. And then they were taken up for the induction. And they had reported that the risk of hemorrhage was greatly reduced. But such cases, once again, I repeat, it has to be dealt in the tertiary center in the medical college where you have all the facilities.
Richa,
Now,
Yeah.
Dr. Richa, actually 50 minutes are there, so we have to wind up earlier. Dr. Parishit
Okay.
also has come.
Okay, I have just few more. I will just finish in another 5-6 minutes. Okay. So now suppose if you do the scan and now you find the placenta accreta in such patients. So again, the most important consideration is that there's no living issue and we have to preserve the uterus in such patients. So now there are various things which has been tried by the researchers. That is uterine artery. You do the uterine artery embolization first, and then you take up the patient for hysterectomy or medical induction or dilatation and evacuation. Now, majority of the cases, the placenta was left in situ, and then after some time, then it was followed by hysteroscopic resection. It was performed under ultrasound or laparoscopic guidance at a later date, and then placenta, when it became non-functional, it was removed. And how the patient were followed up by the SCG till the SCG became normal or the blood flow was reduced at the placental interface. So these are the various options how we can proceed in such patients conserving the uterus. Now, another option is that if a patient, if they come with a previous cesarean, 2 cesarean or 3 cesarean, and then baby is having anomalies, and then how to proceed in such case. Now, if they have a 2 or 3 cesarean before, it is very simple to do the hysterectomy and the ligation, that is one. But then again, where we have to preserve the uterus, we have to think about it. So as far as a prior scarred uterus goes, the risk of uterine rupture is very low, 0.3%, and there's no significant difference in the outcome for the woman with previous cesarean has been found in 1st trimester. But after 14 weeks, the data is very much limited. So there are various studies which has been done, and the various researchers, they have reduced the dose. That is, after 12 weeks, usually 400 micrograms meso is preferred, but in scarred uterus, they have reduced the dose, that is 200 micrograms, and they have prolonged the duration of action. Instead of 3 hours, they have prolonged to 6 hours. So, and then they have reported that the successful termination was there, 82% was the termination rate. And then other which has been tried is the previous cesarean with IUDs also in 2nd and 3rd trimester. That is a tablet mifepristone, 200 milligrams 3 times a day for 48 hours. So now they have reported that the expulsion rate was quite good. That was about 74%. Another person who found the success rate was 90%. So these are the options which we can also use where the baby is disregarded, as in the cases of MTP in second and third trimesters. And this was another study where the prostaglandin E2 was used in the previous scarred uterus and the Foley's catheter.
नोजर सर को लिंक नहीं मिला बेटा, नोजर सर को लिंक नहीं मिला, उनके मेल पे शेयर करो.
That hyaluronic injections were also given, and then also the results were good and there was no rupture rates. So this is another good option where we can use in the scarred uterus. Now these are the last two cases. Quickly I will rush. Now other case, now patient had come at 6 weeks for MTP and IUCD insertion, and she has undergone surgical evacuation. POCs were removed.
Richa, we have to wind up, beta. We have to wind up.
Yeah, but done.
Yeah, quickly.
Yeah, we are too much behind schedule. Yeah.
Yeah. So this was a patient
Yeah.
actually
We
on
will
6th
discuss
day
in
came.
the next webinar. Richa.
Yeah. So
Yeah.
this is the last case. So I just want to highlight this patient was a heterotropic pregnancy. And another patient, again, this was a scarred pregnancy. So I just want to highlight an important point that a patient with previous scarred uterus, ultrasound is very, very important. And even the early pregnancy also, ultrasound is very important so as to rule out the ectopic heterotropic pregnancy also. Though the percentage is very less, but the chances are always there. And now the government, they have given the funds for the Ayushman Bharat and the insurance company. So they also have included the ultrasound. So my message is that ultrasound as far as possible should be done before MTP if the facilities are there, so as to avoid the untoward complications and to be free from the litigations also. So with this, I quickly wind up and thank you so much. Better to do something correctly than not at all. Better to be safe than sorry. Thank you so much for patient hearing, and thank you ICOG for giving me the opportunity.
And thank you, Richa. Thank you so much. Your cases were really, eye-opener and very good platform for all the delegates to learn how to manage the difficult situations. Yes, Bharti, now let's invite Parikshit for his talk. Parikshit?
Yes.
Can you share your screen? I think first slide will be your CV
Yes,
slide.
certainly.
Yeah.
So that's my CV slide, if it's visible.
Yeah, everyone knows you, Parikshit. You are the treasurer of FOGSI and a great academician and orator. So we invite you to deliver this talk on MTP in second trimester clinical aspects.
Thank you. Thank you, ma'am. First of all, my apologies. I just got held up. I'm in the hospital. My thanks to Dr. Shikhande for this kind invitation to be with all of you today. And as the chair, she has been doing an absolutely fantastic job in terms of the value academics that is being delivered through the FOGSI ICOG web series platforms. My thanks, of course, to the entire ICOG team, including the vice chairperson, that's Dr. Biniwale, and the secretary, Dr. Ashok Kumar. And of course, the FOGSI team is strongly behind ICOG, Dr. Pai, Dr. Patel, and all of us office bearers. Dr. Bharti Maheshwari has been the anchor for this series. She's the convener. And I'm really, really honored to be speaking in a webinar where the experts are Dr. PK Shah and Dr. Noza Sheriar. It's really a fortunate day. So I've been asked to cover MTP in the second trimester, Surakshit Garbhapat in the second trimester, the clinical aspects. So a lot of work has been done in the last year, and this was through the Respectful Abortion Care project, which was a joint project initiative of FOGSI and WHO. Of course, this comes on the back of so much of activities regarding MTP, but this particular module has been very useful because it educated FOGSians about the new amendments which have come in. When we talk about Surakshit Garbhapat, safe abortion, what is it that we are exactly looking at? There are two very important aspects: appropriate methods, trained person. So one is when you say trained person, that really is the entire gamut of all the medical legal requirements that need to be fulfilled. And one says appropriate methods. That's the entire aspect of clinical safety, which needs to be looked into in terms of a good outcome. The MTP amendment journey, and today we have one of the, I should say, principal architects who will be speaking just after this talk. That's Dr. Sheriar, of course, with so many other stalwarts in FOGSI and outside FOGSI who made this possible. And ultimately, we've come to the point where this has become law. Now, keeping this in view, some very important aspects as regards the second trimester. The gestational age, as we know, has been enhanced from the upper gestational limit of 20 weeks to include a little further. We have gone a little further to 24 weeks. And this enhancement, please note, has not been universal. This enhancement is for certain groups of women only. So who are these categories and who are these vulnerable women? Those who have survived sexual assault, rape, incest, where the pregnancy has to be terminated on humanitarian grounds of a disaster, which has been declared by the government. There is a change in the marital status of that woman. She has become widowed or divorced. A woman who has physical disabilities as per the Disability Act. She has mental disabilities, she's mentally ill. If it's a minor, then all these come under the category of vulnerable women. And of course, then we have the more special category of fetal malformations where there is a substantial risk that the baby will be born incompatible with life or seriously affecting the outcome of life. Then also you can terminate the pregnancy. And for the fetal abnormalities, there is no upper gestational limit. This has to be done in accordance with the diagnosis and recommendations of a medical board, which brings us to the grounds or the indications why we can perform a medical termination of pregnancy in the second trimester. So when we look at indications, risk to the mother, here the entire onus or the responsibility to judge lies with the registered medical practitioner. That's you and me. Fetal abnormalities, gestational age limit is enhanced even more. Formation of boards is something which has not happened as it should have, and it's not universally there. It is happening on an ad hoc basis, means the board gets formed for a particular case, it gets disbanded, forms again, so on and so forth. But that mechanism has to now get smoothened out. Sexual assault, again, the gestational age has been enhanced till 24 weeks. Failure of contraception, any woman can have a failure of contraception, not only a married woman. Again, it is extended to woman and her partner. Type of contraception is not specified. And then, of course, we have socioeconomic grounds, which is a completely subjective kind of an assessment. Now, who can terminate a pregnancy? One RMP only till 20 weeks. So, well into the second trimester, a single registered medical practitioner is adequate to make the certification. 20 to 24, you need 2 RMPs. And beyond 24, when it's a fetal abnormality which is incompatible with life or affecting the seriously affecting the quality of life, then you have the medical board which opines and gives the criteria. Now, one may wonder, okay, so what's so great? 1 RMP, 2 RMPs, what difference does it make? Well, to people who are practicing in a group or in a hospital where there are many gynecologists around, it's not a problem. It's just a question of getting a signature and completing the paperwork. But if you imagine the situation in a relatively remote area where there is maybe one gynecologist for 30-40 kilometers around, then this becomes a significant barrier which has been removed from the access to abortion that we are providing. Where can pregnancies be terminated? This is in a hospital established or maintained by the government, or a place which has been approved for the same by a district level committee, that's the DLC. Consent, again, all the important aspects of general consent are important, but in MTP, well, it's very, very important to note that an adult woman requires no other person's consent under the law except her own, even if it's a second trimester abortion. Other people's consents are quite superfluous. Hospitals take them for so many other reasons, like for the sake that the woman is admitted, they'll take a consent, that's fine. But for the legal aspect of MTP, it's the woman's consent and the woman's consent alone, which is important. Privacy and confidentiality, there is a new insertion in 2021 amendments, and there is also a very, very high premium which has been placed on the privacy of the woman. These are all the documentations which are important for conducting and safely conducting the MTP. Safely for whom? For you and me, for the practitioner. So you have your form A, B, and C, which need to be in place. A is the application, B is the certificate of approval, and C is the consent form. So A and B are generally one-time events. C is something that happens case to case every time. Then you have your form 1, which is the form certifying your opinion that this pregnancy should be terminated. That goes into the envelope. There's a form 2, which is a monthly statement of cases, and a form 3, which is the admission register. Again, everywhere the confidentiality must be maintained. Name should not be written at all. And the OPD case sheet also, there is a bit of controversy, because if there's an electronic health record and the woman enters the, say, a corporate hospital, then how can it be not disclosed? That becomes an issue. Some gray areas exist, but we have to see that the essence of the law is maintained. Just some important pointers when it comes to documentation. Proof of identity and age, not mandatory. If it's a minor, FOGSI Act will come into play. There is nothing like a proof of marriage that is required for performing an MTP. It's not needed at all. Consent has to be taken in Form C. As I said, other formats of consent are taken by hospitals, clinics for their own satisfaction, but they are superfluous and only the woman's consent is needed. Just some samples of how forms need to be maintained. These are all ready-made formats which are freely available across various sites, and of course from various commercial vendors also. The same material just printed nicely so that you can file it and keep it safely. And this is the register which has to be maintained in that particular 14 column format. Now, coming to the core clinical part of the work, I always work up these situations, these women, just as if I'm doing a major gynecological surgery. Someone might say that, well, that's a bit of an overkill. Why do you want to do all those things? Because you never know how these situations might turn out. Ultrasound, again, not mandatory, but I think in today's settings, it would be completely imprudent and unwise not to do an ultrasound before a second trimester. Blood should be cross-matched and it should be performed as an indoor procedure. You might give priming, we'll come to as outdoor, but once the main induction process starts, it's important to have the woman under observation. Now, the WHO in 2018 has made these recommendations as far as termination of pregnancy protocols are concerned. And today, really, mifepristone and misoprostol are the route or the pathway of treating these women. Mifepristone as a single oral tablet of 200 milligrams, given 1 to 2 days before, 24 to 48 hours, that can be a bit flexible. I mean, it's not such a rigid timing. And then it's followed by misoprostol. 400 micrograms every 3 hours. The route is not so important. It can be buccal, it can be vaginal, it can be sublingual, doesn't really matter. There have been misoprostol only regimes which have been described. The completion rates are a little lower at the end of 24 hours as compared to mifepristone plus misoprostol. So there is an advantage of adding mifepristone before doing the induction with misoprostol. Now, the thing is that when we are looking at misoprostol, there's nothing like a loading dose. I mean, this was one of the practices that, before you start your 400 microgram dosing, you give one 800 microgram dose upfront and then start your 400. Nothing of that sort. Moistening misoprostol does not change the efficacy. You may moisten it. It adds a bit of comfort. Vaginal route is most effective. I mean, even though the recommendations say that you can use buccal, sublingual, or vaginal route is the most effective, but you have to take the patient preference into consideration also into this recommendation. Now, there's no recommendation by the WHO as to how many repeat doses can you do of misoprostol in 24 hours on the next day. Well, there's nothing really that is mentioned in the guidelines. But my practice is to stop at 4 doses in 24 hours. So just practically speaking, we begin early in the morning. Early, I mean 8 o'clock, not very, very early. And by 5, 6 o'clock, if she has not aborted, then I'll call it a day over there. I'll stop the process over there and come back the next day. If it's a previous uterine scar, well, you must have heard this so many times. Be mentally and clinically prepared. Be vigilant. What's important is keeping things prepared. You may be prepared and you may be aware that, oh, this woman might have a uterine rupture. But if there's no blood, if you're not informed the anesthetist that, I have this patient whom I'm inducing, if the theater nurse doesn't have the autoclaved instruments, then what preparation is that? Mental preparation is okay. We get prepared in 1 minute. Same dosage regimen to be used even with previous uterine scars, because the lower segment isn't really formed. So you aren't really having a very high risk in this kind of situation. Now, mifepristone and misoprostol are the gold standard, but about 10% are not completed at the end of 24 hours. Now, what do you do? As I said, no recommendations. So everything is based on experience from this point onwards. What I would suggest is that you relook at the clinical scenario and make the decisions based on where the woman is in that entire process, in that journey. What we usually do at this point is, as I said, we stop at 6 o'clock in the evening and then come back the next day and repeat with different brands, different route. If you've predominantly used vaginal route, use a sublingual and buccal combination. Use other prostaglandins if this does not work. That may be in the form of a dinoproston gel, or more recently, I've used the dinoproston pessary on a couple of occasions where misoprostol didn't give me the result. But do not use carboprost injections. That's not okay, because that can really make a high risk of the uterus rupturing. If the woman has started effacing out, I mean the cervix is effacing and the lower segment is forming, but she's not opening up, you might consider a concentrated oxytocin infusion given in an infusion pump. You could put 20 units of oxytocin into a 50 ml solution and then titrate it. Other option, extra-amniotic saline infusion and mechanical cervical ripening. This is what we grew up with when we were residents. Today, of course, ethacridine lactate is no longer available. So you just use the saline, inflate in the extra-amniotic space as many weeks into 10 gives you the amount of saline to be infused. So if it's an 18-week pregnancy, then you can do 180 ml. That's the rough calculation. And then you inflate the Foley's balloon and hitch it to the cervix. That gives you a mechanical ripening. And rarely, now this is where you'll hit 99% of procedures should get completed with all these excuse me, all these various maneuvers. Rarely required second trimester dilatation evacuation. do it under ultrasound guidance. It adds a layer of safety in terms of preventing uterine perforations also and ensuring completeness, and hysterotomy very, very. I mean, typically people who do second trimester abortions routinely in their lifetime will probably be still in single digits in terms of, number of hysterotomies done. Clinical care, well, as I said, keep hospitalized, keep her mobilized and on full orals. There's no need to keep, prolonged NBMs. Antibiotics, if there is clinical or lab evidence of sepsis, the membranes rupture, or there have been more than 12 hours have passed since the start of induction, then I'll cover with antibiotics. Pain relief, all the options, whatever are suitable for the woman and the care setting can be used, including epidural. So everything should be used to keep her comfortable in these few hours, which can be as agonizing as a labor. The next question is, once the products and material starts getting expelled, is it complete? Check the products, especially the placenta. Avoid doing any intrauterine palpation, digital examination to see if there's a small cotyledon or some twigs of membrane remaining. Don't do all those things. If you have a doubt that, there's a significant, you feel that one cotyledon has not come out, do an ultrasound and confirm whether it's out or it's still retained. And then you may have to do surgical uterine evacuation where there is bleeding and there is some retained product, then you have to do a surgical evacuation just as usual. Post-abortion care, medical disposal of the products in a humane manner, provide timely and appropriate contraception, and arrange for follow-up visits as per the standard protocol. Second trimester abortion is something which always makes people wonder that, okay, why did the woman not come earlier? Why did she have to wait till the second trimester? It's just circumstances. And all I can say is this quote, that we still need abortion as early as possible and as late as necessary. So providing second trimester abortion is really a part of the entire clinical services that need to be offered to women who need them. So once again, thanks for your patient attention. And again, my apologies for derailing the program a little bit. Couldn't help it. Sorry. Thank you.
Thank you, Parikshit sir. And we are happy that now we have our expert, Dr. Nodar Sharyal sir, that he has joined. And we all know that Dr. Nodar Sharyal, he was a past Secretary General of our FOGSI. And ये थोड़ा मेरे control से Dr. Nodar Sharyal, yeah. And past MTP chairperson FOGSI, and I have learned a lot and work done with him in my tenure MTP committee. And we all are familiar with his work and dedication for FOGSI. And he's a past president MOGS, and at present he's in Breach Candy, Hinduja Healthcare and Holy Family Hospital. Sir is a fellow honoris causa RCOG, AOFOG Young Gynaecologist Award, and had lots international credits in his tenures and all. So I request Dr. Nodar Sharyal sir to please share your slide. I'm stopping sharing, and we all are eager to hear you on MTP issue.
Welcome,
Dr.
Nodar.
Lakshmi madam is here. Yes, madam.
Thank you, Lakshmi, Bharti. It's such a pleasure being part of this program. Bharti, thank you for the opportunity and for allowing me to speak some of my ideas and views at the end. And I'm amazed to see the number of people who are on this program at this time. May I share my screen now?
Yes, please.
Thank you. Okay. Yeah, can you see my screen?
Yes.
Right. So this is a picture that I like to see again and again. This is a woman Many years ago, this was a picture from the 1970s, who went to a hospital in Chile, which was one of the countries in the world where abortion was not legal for any indication, not rape, not maternal life, nothing. And she went and told this doctor that this was a 26th illegal abortion. It always made me wonder, why does a woman go through something like this 26 times? And when you think about it, I think the answer is because she has no other choice. And whatever we are doing today and whatever I believe, I'm partial to the MTP committee in FOGSI. I think all FOGSI committees do great work. But I really feel that the one place where you can really know what you're doing for women's health and rights is about what you do for her right to safe abortion. Now, obviously, that was Chile. Abortions were illegal. We are India. Abortions have been legal since 1971. And yet my colleague at one of my hospitals, Holy Family Hospital, had a patient who came to hospital in 2018, just 5 years ago, with a foreign body in a uterus. Mumbai city, in India, with abortions legal since 1971. So if anyone thinks we've solved the problem, sorry, we haven't. That was a great presentation. I was there for most of Parikshit's presentation. We have our work cut out. Because Yanda has said when rights to abortion and reproductive health are restricted, those at greatest risk suffer the most. The poor, the marginalized, the young, the unmarried, they are the ones who will suffer. I'm going to talk to you today about my view on the abortion care that women require. It's something that kind of I've developed over many years. And trust me, when I became the MTP chair of FOGSI, it wasn't out of choice. My mentor, Dr. Hansotia, forced me to be the MTP chair. And for me, it changed my life. And I realized that this was the purpose of my life. I mean, I love obstetrics, I love endoscopy, but this is the purpose of my life. So first, let's see what women require and what women deserve. They require that abortion must be common. At one time, the IPPF had a statement, abortion to be safe, legal, and rare. I fought the statement. I said, abortion should be safe, legal, and common, not rare. Because this is an estimate from 2020 to Guttmacher Institute. The estimate is that every year in the world, there are 73 million abortions. Remember that number, 73 million. Keep saying it again and again to all your patients. So Guttmacher Institute has a model and they apply the model every year. It's a very scientific model and they say that you have 120 million unintended pregnancies in the world and abortions happen in 73%. Now, I'll just go through this very quickly and basically this tells me two things. This tells me whether the abortion is legal or whether the abortion is illegal. The prevalence is exactly the same. It does not become any less wherever you go in the world. So if you think you're banning abortions, trust me, you are only banning safe abortions. You're not banning unsafe abortions. And if you look at the left, you will also find that the sorry. And when you look at the low income, high income, and middle income countries, you will find that the abortion rates are higher in the countries where very often it's illegal, which is the low and the middle income countries. Now, this was a study done in India. I want you all to know about this study because this was a landmark study where they estimated that we had 15.6 million abortions each year in India. It was an amazing study in 6 states, which was then projected to the country. These states had 45% of India's population. 4,000 sites were surveyed. And finally, this is what they came up with. Today, the estimate is that India does 17 million abortions. And every time I do an abortion for one of my patients, I ask her, do you know how many abortions there are in India? And she says, no. And I tell her that in India, we have 17 million abortions. The moment I tell her that, she feels reassured that she is not alone. The next thing I believe is women require and deserve that abortion be accessible. Now, when you looked at that study in India, what did that study tell us? The study told us that today, medication abortions are the majority. Today, health facilities only deliver 20%. 73% are outside health facilities. Medication abortion in health facilities are 1.2 million. Outside health facilities were 11.5 million, which was 12.7 million medication abortions. Sea change, something you have to accept. Many of these are from our clinics, which are not healthcare facilities. Many of these are self-managed, which if you are someone who cares for women will understand that a woman does this when she doesn't have a choice, and what can we do as an organization to support her. But what's really bothering me is that 500,000 abortions are still extremely unsafe, being performed by very unsafe providers. Now, there is the reality of self-managed abortions. Whether we like it or not, I believe today that a majority, more than half the abortions of the world today in many countries are self-managed. And this was a WHO statement which said that there is a shortage of 18 million health workers and at least 400 million people lack access to essential services. And the WHO says that self-management of medical abortion is one of the safest and most effective options of abortion care. Well, that is where the whole WHO document is. I know nobody is going to support this, not us, not FOGSI, not the government. Well, the question is, are women asking for our support or are they just doing it? Now, what happens when a patient has a medication abortion? We worry. What will happen about complications? Don't we look after incomplete abortions in nature? Don't we look after ectopic pregnancies in nature? Why then are we afraid when this follows a medication abortion? And this study by IPAS in Madhya Pradesh showed that when there was a complication of a medication abortion which a woman had taken herself, she did not go to a quack. She went to a doctor. In fact, by the third visit, she was with a private doctor, a government doctor, or a nurse. She was no longer going to anyone unsafe. And in fact, this is something I can tell you from the time we had done some work with PSS. At that time, Jaideep was the MTP chair. And I remember that we had come up with this very simple visual guide for women. We had even tried to convince the other pharmaceuticals to put this in their packs. Unfortunately, it didn't work. We told the government, tell women what will happen if there is a problem, so that in case the woman has taken it herself, all these pictures, excessive bleeding, severe lower abdominal pain, diarrhea, will allow that woman the information to go and seek perfect health. The next thing I believe is women require that their abortions stay updated. I love this. James has said technological discoveries are the spermatozoa of social change. MVA. Certain things I'm extremely proud of. FOGSI championed MVA. People said MVA was useless. FOGSI convinced the government. We did a multi-centric trial and we showed MVA is as good as an electric pump. And in fact, when we did our study in FOGSI, because we were constantly quoting the same data from Green Slate, and this was a study that I had published with Jaideep and with Bela Ganatra from the WHO, then in IPAS. We showed, and this is the strength of FOGSI and ICOG. Within a few months, 3 months or 4 months, we had 1,600 procedures, high quality scientific study, which showed how safe MVA is. And then we took that information and FOGSI did a multi-centric trial for the government. It was called the MVA pilot project. We trained 120 doctors in MVA who had never done MVA before in 2 weeks. 8 states, 2 districts. We asked them to send the nurses. And trust me, that's what brought MVA into RCH2. Another great thing was the acceptance of medication abortion. This was a paper published where we asked FOGSI members, first of all, we were proud to find that we don't have conscientious objectors. The Indian gynecologist performs abortions without giving it much thought. Back then, we were already using the perfect dose of mifepristone and misoprostol when the companies and the world was telling us differently. And year on year, the sales kept on increasing. And that showed us that today we've shifted completely from a surgical-based abortion country to a medication-based abortion country. Now, there we had the advantage of being at the table when the comprehensive abortion care guidelines were written. And back then, again, this was FOGSI telling us way back in 2002, we suggested that up to 49 days, use 400 meso, and after 49 days, use 800. WHO said, no, it has to be 800. When you look at the WHO guidance now in 2014, they say that if less than 7 weeks, 400, and if after 7 weeks, 800. Now you may say, what's the big deal? The big deal is when a woman is taking a medication herself, you and I know that 800 is going to give her rigors. 800 is going to scare her. The rigors may not be dangerous, but we know that 600 and 800 micrograms of meso does that. And wherever possible, a 400 microgram dose, if it does the job, is better. And we done this whole training video from FOGSI. And at some point in time, I'm going to tell Bharti and the new chair, Richa, that please dig these out and put them on the website, because FOGSI has these resources. We shouldn't waste our resources. We should keep using them. This was the GCPR we did in Pune. And back then we had suggested mifepristone, misoprostol, when in India it was considered illegal. This was 2004. And again, when we were there, people asked, is meso legal in India? It's not approved. All I tell them is whether it's approved or not. The government guidelines of, they are now 2018, but we first did them in 2010, said that mifepristone and misoprostol presently not approved, but evidence recommends the use and it is safe and effective, and they've given the protocol. So if the government guidelines are telling you the protocol and telling you it's safe, I don't see how anyone can get you into trouble in a court of law. And these were all the RCTs, which shows that a combination is the best. I heard Parikshit spoke about it beautifully. Initially, WHO said loading dose. We said no. We go with the standard 400 microgram dose. So Parikshit, I must say, once I start, I don't stop. I don't stop in the evening. I don't stop at night, and I don't even stop at 24 hours, and it almost always works. This is another thing about whether abortion can be simplified. Now, first, there is the option of home-based abortion. The government guidelines, the guidelines that we'd written in the All India Institute actually said that you can allow home-based use of Mifi and Meso if the provider so decides. You don't have to do it in a clinic. It improves privacy, it is convenient, and I can tell you myself, I have been doing this forever. My patient comes in for a consultation. Very often we do a teleconsult for history. She's told to do the investigations. She comes in, she gets an ultrasound, she's counseled, and then she's sent home with the medication. And we have found complete home administration in 340 patients. And we have found that post-procedure, we are successful in almost each and every case. What about telemedicine? I'm excited about telemedicine because we know that during the pandemic, we switched to telemedicine. And I believe that a lot of abortion care till the law allows us to take the signature. And today you can take a digital signature, can be done by telemedicine. And this was a study that happened. The RCOG said that when the telemedicine was used for 50,000 early medical abortions, there was no further intervention in 98%. Less than 0.05% had a serious complication, and women preferred. And I'm wondering whether in our country that is probably the way forward. And finally, I'm going to talk about what I feel very strongly about. And what I feel very strongly about is last mile connectivity. And when I talk about last mile connectivity, this is a WHO document. And this particular document talks about the role of a wide range of health workers. And if you look here, if you look at doctors of complementary systems of medicine, what we call the Ayush doctors and the nurses, we showed again in a publication in the Indian Journal that they have the capacity, and maybe if not in the private sector, if in the public sector, at the grassroots, at the PHCs, we had these people trained and approved, then women may not have to suffer as far as getting their abortions are concerned. Finally, I believe women want abortion to be empowering. I'm not going to go through these in detail because Parikshit touched upon many of these things. And you can see Section 3 of the MTP Act now, where you've extended to 24 weeks. We also had a lot to say as far as that is concerned. And I think it's time for us to champion abortions. This is what the MTP Act is now, 12 weeks. Unfortunately, we had requested that it should be on request. It's not. 20 weeks has remained, thankfully, with a single provider, and up to 24 weeks, 2 providers. And after which, the one big disappointment that, again, I have is the fact that we have to depend upon a medical board, which according to me is the worst. I think finally, stigma is something that you can see when it comes to abortions. And this is something I tell all my patients. I tell my patients that if 72 million women are doing it, it can never be immoral or wrong. And yet there is stigma, it marks, it segregates, it marginalizes. And I think it's time for us as doctors. We are the caregivers. We have to speak up for them. We have to give them the confidence. We have to be their advocates. We have to be the champions. We have to be the confidants. And I believe we have to be their co-conspirators, because that's what she comes to us for. Bharti, I think I'm going to stop here. Thank you so much. I'd love to, reply to anything or participate. I think this has been an absolutely great program.
Thank you so much, sir. I have seen you working in this area. I think more than 2 decades you are working towards providing safe abortion services to our women. And I know you want it to be by paramedical workers. In my review talk, I was talking about the telemedicine for the medical abortion. I am so happy that you also touched that aspect, that telemedicine for medical abortion is the way forward. And you have shown your data also. So I'm sure we are moving forward, and your passion towards providing safe abortion services will be motivating all FOGSians to do the same. Thank you, Nozer.
Thank you.
Thank you, sir, for a wonderful talk. And in fact, it is very inspiring for all of us, those who are listening. And this whole journey, you came in like a picture. And really, we have progressed a lot. We come a very long way. And that is all of you were associated with all the work you have done at the root level. And that's why today we are at this stage. And we continue to do work so that we can have I think, minimal mortality and morbidity associated with abortion related. So thank you very much for sparing time and coming in this webinar. And thank you, Lakshmi Madam. And now I request Lakshmi Madam to say concluding
PK Shah
remarks.
sir is here. Bharti, PK Shah sir is here. 2 hours he has logged in and he is listening to us.
Who is that? Who is Dr. Lakshmi?
PK sir is here. PK Shah sir was here.
Dr. PK Shah sir, I am not able to see.
Logged out.
Just now he was there.
Yeah. because
Yeah,
he was
long
here.
time he was there, but at present he is not there. Yeah. So you can conclude, Madam, Dr. Lakshmi, Madam.
Nozer has already given so many take-home messages. Parikshit, Richa, you yourself conducted so well that panel. The correlation between MTP Act, the FOGSI Act, and the PNDT Act, where the many controversies and day-to-day problem arises for our FOGSians. So I am happy that we have clarified many, I will not say all their practical problems, but many of the problems we were able to answer. So thank you, Bharti, for coming out with this module with the excellent talk and super speakers like Nozer, Parikshit, Richa, and you yourself. I am so happy that we have done justice to this Chai Pe Charcha, that is Surakshit Garbhapat Beti Bachao ke saath.
Thank
Yes.
you, Madam, and I am happy that some great speakers could come in my webinars in both times. Dr. Anoja Sharyar has agreed to come and not even only give expert comment, but he has presented also. So I am really blessed and very grateful to sir. And Dr. P.K. Shah sir, Richa, Dr. Parikshit, they have done really excellent presentations, very useful for all of us. And Dr. Lakshmi Madam, you yourself not only organizing, but you are giving your time to presentation also. So thanks all audiences. And of course, we have very good documentation what we have made. FOGSI Focus, the Dr. Nozer also has chapter, Dr. Shama said also, and all PK Shah sir all have contributed in. So we can get that from the FOGSI website also. And those who want hard copy, I can send them, and as well as my presentation and whatever information me and Dr. Richa, she's the present MTP committee chairperson, and Dr. Lakshmi is the ICOG chairperson. We all can provide you. Thank you. Thank you very much.
Thank you all. Thank you.
Thank you. Bye bye.
Jignesh, recording stop kar de. You can end the meeting.